confidentiality, and I don't want any any unintended consequences of sharing that information in a public board. And I'm sure Denise probably wants to come in on that point at this time. I don't know.
Denise, we'll go down to you, Denise. Seeing as you've been honorary and mentioned.
Yes, I wasn't going to comment on this particular, but yes, Alistair, we do actually at the Quality Committee, we do look at the detail of the information that's provided in regards to each of the serious incidents, and actually we are looking to see if there are themes or any areas that we need to go and investigate and get further information. So yes, we do actually spend a fair bit of time at Quality looking at serious incidents.
Thank you. And is there any reason for that you can see for the increase between February? Is that due to an increase in COVID cases, increase in ED admissions, or any other reason?
It's a real mixed bag, Alistair. It's a real mixed bag. There isn't any. I can't see a link as to why there's been an increase. So no, there's no. It's a different set of circumstances.
Okay, thanks.
Richard, you waited patiently, and apologies for jumping to Denise, but back to you, Richard.
No problem. Thank you. Ellen, my question is around sort of falls and pressure ulcers. We noted it to some extent at F&P early this week, and you highlighted falls in your report, and I noticed that Denise in her chair's highlights report for Quality Committee also noted that. On your report, there are quite a lot of reds against pressure ulcers in terms of achievement against objectives. We've always felt that this was to some extent linked with staffing issues and staffing shortages. I just wanted to get a feel from you as to, on the assumption that those staffing issues, they may well improve slightly over the coming months, but they're going to be a challenge going forward. And just to get some assurance about the actions that we're taking in both of those areas to address, those challenges.
Yeah, so what we've introduced, Richard, is a weekly high impact action review. So where we've had a pressure ulcer and a fall, we invite the band 7 for that area and the matron in, and that is a multi there's a range of people on that call, from tissue viability, from matrons, from corporate nursing services, and we go through those incidents in quite forensic detail, and then we put in place a plan of action to support the divisions and the directorates in making some improvements. There's no doubt that we have a number of escalation areas open at the moment for obvious reasons, and so our staffing levels have taken a hit as a result of that. We closely monitor the impact of staffing, and we do all that we can in terms of making sure that everywhere is safely staffed. But over recent weeks, we have seen an increase in COVID sickness and absence, so that has been a challenge. The other area that we have reintroduced is, as we are having a cautious reopening of visiting, I think we've missed an opportunity with some of our relatives to be sat at the bedside. So, relatives contribute in a very informal way to care hours, and we're having a real push around making sure that any exceptions to the visiting policy that we do that we do make sure that we're sticking to those, and that we can get relatives back in to help support us with some of that. A, understanding patients, and B, just being there. Increasing the number of volunteers in the ward areas will be really helpful, and Suzanne referenced some of the safety guardian work, so we can start then reintroducing some of those that will have an impact. But I can't stress enough that the patient acuity has gone up. Our patients are older, our patients are sicker, and this is having an impact on that. So yes, we absolutely will see some improvements as our recruitment, our numbers of international recruits, and we we're still working on our vacancies around healthcare support workers. One of the high impacting actions that I've introduced as a result of the weekly meetings is that we're looking at physiotherapy assistants in some of the ward areas to go round to be looking at falls assessment to make sure that we've got everything we need in place, and as dedicated fall support to those clinical areas.
Thank you for
Thanks,
that response, Ellen.
Response.
I'll now move down to Andy and then Denise.
Ellen, I guess it's almost related to where Richard was. So I was looking through the report and I find myself every time going to the Quality Committee, it's a very thorough report. So there's lots to read there. And I come away going, there's action against everything, which is great. You know, you get real confidence that stuff being done. And some areas, pressure ulcers, falls, a couple of examples, complaints, must assessments, seem stubbornly refusing to shift despite seeing lots of actions and focus. And I guess maybe it's to repeat what you've been talking about. Is that kind of the last year or so driven by factors like staffing and acuity of patients? You know, when you look at it, you know, you're taking action, I'm sure, and it's just not shifting some of them. Is there something different we need to do, or is it a factor of what the environment we've been operating in for the last 12 months or longer indeed?
Okay, so I think the introduction of the focused J2O reviews is really, really helpful. And where we need to get to around that is around the level of local assurance to make sure we're absolutely rigorous in our approach to looking at where we are with some of these key indicators and closing the loop, because it's no good it happening at Quality Committee only. That needs to happen at very local level. So there's something about, and again, we've referenced it a couple of times, around what is the role of the leadership, visible leadership in all of this. And in my view, it is about having a look at some of those key risk areas and actually then it's not about checking up, it's about supporting, and it's about removing some of those barriers. So again, as we get our leaders back into the offices more, then we can, you know, we've increased our resource for that eyes on, boots, you know, boots over the threshold approach, not in a checking up way, but in a really supportive way.
Okay,
and you would hope
thanks.
that's a key difference in behaviour that drives a shift. You would hope in some of the, because you recognise, I'm sure, like I said, isn't it? There's some areas where keep pushing and we just haven't pushed it further. Okay.
Okay, thank you.
Right.
Denise, you wanted to come back in.
I did. I know that we went through the report in quite some detail at our last Quality Committee. Just one thing I wanted to pick up, Ellen. I'm not sure if it's a typo, and it's around end of life care in terms of focus, quality, priorities. And there's a note that's been made that, and which is really good to see, that we are going to be moving to 7-day working for the inpatient acute palliative care service, but it's making reference to that starting in September 2023. Is that a typo, or is that the case that we can't start it before September?
No, it is a typo. It is a typo, Denise.
Okay,
yeah,
lovely.
Thank you.
Okay, thank you.
Any other questions or comments to Ellen?
You've just gone on to mute, Philip.
Does that when I touch it sometimes. When we've noted the quality report, we're now going to go to the high level risk register, which is to approve. I'm not rushing anybody, but time is going on at a pace. So I'll just leave that with you, Helen, to work out how you want to respond to that. But it is a paper to approve, so we don't want it. Okay, over to you, Helen.
Yeah, I was going to say exactly the same. The paper talks about our existing top risks. It points out that there's been no new risks proposed, no increased risks, and we've got some narrative there around those risks with a reduced score. It's been through risk group, it's been through Quality Committee. The only comment I'd make is around medical devices, and I think we need to just be a bit clearer in the narrative on some of that. I don't know if anybody else had to read it a couple of 3 times, so I think we can improve on some of that, but I wasn't intending to take us through it in great detail, Philip, if that's okay. There's your...
Any other questions or comments? Andy, you wanted to ask a question?
Just two quick comments. So one, we had, because risk group reports into audit risk committee, we had a deep dive from Kim Smith and Lisa Cook at that committee, Ellen, and I have to say genuinely encouraged by the work they're doing and trying to improve the risk process, some of the stuff they're doing. And I've tested that out in divisions on receiving end of that. Again, I've had positive feedback, so I think that's really good to see. And if I had just one general challenge in this report, though, if I had a criticism of it, would be a number of the risks are right up to date and quite a number of them aren't, you know, in process terms have been fully updated. There will be some specifics, but I'll take those offline that I'd like to ask about.
Thanks, Andy.
Any other questions or comments? Are you happy that we approve this report? The next item on the agenda is the integrated performance report. We may or may not hear. Oh no, and she's gone to Andrea's workstation. Just to remind you, I hope you don't mind me reminding you of this, but this has already been through the Quality Committee and the Finance and Performance Committee. So just the headlines, please. That would really help me try and get. But again, I don't want it to feel that you've not had a chance to say anything you wanted to say.
That's fine, Philip. Headlines, all domains for March are amber. The report obviously notes that we still continue to see rise in attendances to A&E. As Brendan referenced earlier around COVID waves, we're still seeing surges around patients coming through with COVID symptoms. Just want to note the stroke standard in the report and our continuing challenge around that. But would like to note we have had a rise in stroke admissions, and that continues. We see a trend there. We don't know what's underneath that yet. More to come on that in the next few months. Just note all cancer standards achieved in March. I think that's a great achievement for our patients and an absolute celebration for our staff and what they've done there. Top numbers, transfer of care delay numbers that everyone wants to focus on remain around average 100. However, we've now had a real focus internally on what we're doing. And again, I'll report on that throughout the year. And just to highlight, that we continue to focus on the one culture of care, health and well-being, as we've talked about today, in terms of our recovery for the year ahead. Those are the key things I'd like to note, Philip.
Thank you for taking my request into consideration. It's really appreciated. Are there any other questions or comments? Okay, well, we're asked to note that, so thank you very much. The next item I've got down is the governance report, and like we've done before, Andrea, we've got compliance with license, delegation for quality account, board of directors attendance register, and board of directors work plan. All of those have to be approved, and then there's the update on the non-executive directors appointments to note. So if you could run all those together for us and just tell us at the various points what you want us to do, that would help me greatly.
Thank you, Philip. Can you hear me okay? Yeah. Yep. Okay. So the first item for approval is a self-assessment process. It's part of our year-end processes for 21-22, and it's a statement that's signed off by yourself, Philip, as chair, and Brendan as chief exec. So it describes a number of elements that we have to self-certify against around having good governance systems and processes, that we've provided training for our governors, that we're compliant with our licence conditions, various NHS acts, etc., and that we've got the resources to continue to provide services in this year 22-23. So the statements are in the papers, but looking for approval for those. I'll just pause there in case there's any questions. Okay.
We're going to approve those because no one said otherwise.
Thank you. The next one is a fairly quick one. So this is about asking for delegation for the Quality Committee design of the quality accounts this year, just as we've done in the past, because the timeframes don't work for our meetings. So
I know that we've done that before, and I'm sure Denise is happy with it, so we'll move that to approval. Thank you very much.
And as you can see, we have two new non-exec director appointments. Both Tim and Nigel are with us today, and there's just confirmation of the appointment process that was undertaken with our full governor involvement in that and approval through the Council of Governors. So that was for noting. And then for approval is the board attendance register for 21-22, as that will appear in our annual report, which is published. And there is a board work plan for approval for the upcoming meetings for the rest of the year.
I recommend that we approve those. Okay, thank you. Does that conclude your business with that bit?
It does, thank you.
Thank you very much. We've got a review of board subcommittee terms of reference. These are slightly altered. There's some red on one of my notes, I think, somewhere. So I'll go to Richard, Finance and Performance Committee, and then down to Peter for Transformation Programme. Is there anything you want to bring to our attention, either of you? Because we have to approve these.
Philip, on F&P, it was really just about giving more flexibility in terms of replacement of non-executives if one of us couldn't attend. So it gave us, it does give us that flexibility. It was approved back in November, actually, by F&P.
Yes. Okay, fine, thank you. So that's approved. Peter, is there anything you want to bring to our attention to approve from the Transformation Programme Board?
No, nothing other than what's there to be seen, so nothing from my.
So you're happy to, you're going to recommend that that's approved? Yeah, thank you very much.
Thank you.
Is there anything now from the chairs regarding Finance and Performance Committee, Quality Committee, Audit and Risk Committee and the Workforce Committee that the chairs wish to bring to the attention of the board? That's very good. Thank you very much. That's to note. And there are items in the review room from Calderdale and Huddersfield Solutions, West Yorkshire Association of Acute Trusts, and the West Yorkshire and Harrogate Partnership reports. Is there any questions that anybody wants to ask myself or Brendan on those? Okay, thank you. We're now in terms of any other business. I just want to say a massive thank you. Oh, Brendan, what are you going to do? I just want to say, just let me finish this. I just want to say a massive thank you to Ellen, who's helped us greatly and for her contribution to the board and the challenge that you've given me personally as a chair. I found that incredibly useful, Ellen, and although I won't be here, we both leave at the same time. I'm sure we'll you will go one way and I will go another, but I wanted to formally have it recorded here that our thanks and appreciation and admiration. So thank you very much, Ellen. And I also wanted to say thank you to you all for having your patience with me. I usually say it at the end of the meeting. I'm going to miss you all. It's been a pleasure. As my grandchildren would say, it's been a blast being chair of this organisation. And I hope Helen has as much fun and as much challenge and as much support from all of you. So thank you very much indeed. Now you can say something, Brendan, if you must, if you need to.
So, Philip, I think yourself, Ellen and Alistair wouldn't thank any of us for embarrassing them. But we do need to record our formal thanks to all three of you. You've slightly stolen all of our thunder, but it would be remiss of me not to put it on record our significant thanks as both a board and on behalf of the organisation to you as our chair for your stewardship, your leadership, your good grace, and the way that you've led us over this past 4 years. I think in the midst of a global pandemic, you're underplayed and understated in your approach, but we recognise just how much you've done for us as an organisation, and we are incredibly grateful for that. And you will leave a very strong legacy for us as an organisation as we go into the next phase. So it's a heartfelt thank you from me and on behalf of everybody around the tiles today.
Thank you. I just want to respond by saying I've been driven all the time through one culture of care. That was the raison d'etre. That's everything I've tested it against. So thank you very much. Can I respectfully suggest that do you want a 10-minute break or a 5-minute break? Can someone suggest 10-minute break? Is that the best for everybody before we come back for the private board? A 10-minute break then. Just for those of you who don't know, you'll have to go out of this meeting now and then re-engage in the private board meeting. So according to my machine, it's nearly 20 past. If we come back at 12:30, the most of the information will be given over to Ellen. So we're on the maternity services. So we'll see where that takes us. Okay, is that all right, Brendan? Your hand's still up. Yeah. Okay, fine. Thank you.
Thank you, Philip. Thank you. Thank you, Ellen. Thank you, Alice.
To get through, there's 300 and odd pages today. So please bear with me as we go through things. So good morning and a warm welcome to the Board of Directors from Calderdale and Huddersfield Foundation Trust. This is the 5th of May. And by the way, it's International Day of the Midwife. So we're here to celebrate that as well. This is a strong reminder to all present that this meeting is taking place via Teams and will be recorded, and therefore it will become public as soon as it is published on our website. Just to remind you of that. Please try and follow the usual Teams etiquette: muted, use the chat room and raise your hand. If you want to speak or you don't feel you're being recognised, just wave your hands around and someone somewhere will recognise you. Now, I think I've got everyone here, but if I missed anybody, I apologise. I would like to welcome Helen Hurst, our chair designate. Thank you for finding the time to do this, Helen. It really is appreciated. And to Nigel Broadbent and to Tim Bushby, who were recently recruited as non-executive directors. Richard Hill, who's presenting the paper later on. Davina, for Guardian of Safe Working. Davina tends to come in, present a paper and then leave, so she'll join us at the appropriate time. For the patient story, I've got Jenny, Alistair, Sarah and Caroline. Because there's 4 of you, can I just remind you to try and keep that presentation to round about 15 minutes, if that's possible, please. And I think we've invited governors for Veronica, Isaac, Peter and Nicola. If any more governors join us or I've missed anybody, then I'm sorry. Just to tell you at the beginning, this board meeting is the last board meeting for Alistair and myself, but I just wanted to record my appreciation and admiration for Alistair on behalf of our board. I'll say something at the end. And I've been extremely grateful for his advice, guidance, leadership, especially with regard to Calderdale and Huddersfield Solutions. So if you're on the meeting, Alistair, a massive thank you, and what my grandchildren would say, I hope I've bigged you up enough because you deserve it. Anyway, you've said thank you. It's also my last meeting, but I'll say something about that at the end. And I've made the assumption, like I always do, that all the papers have been carefully read. And so therefore, could I ask the authors of all the papers just to draw to the attention of the board the most salient points, and then we can open it up for discussion. But just to remind you again, this is a meeting that's being recorded that will become public on our website. So that's the welcomes out of the way. I'm just to check with Amber. Have I missed anybody, Amber, that you are aware of?
No, you haven't. We've just got apologies from Peter Bell, one of the invited.
Yeah, I understand because he's not well. Declarations of interest. Can I remind everybody to declare any interest over and above what they've already declared if anything appears on the agenda? If in doubt, my advice to you is to declare an interest. Minutes of the previous meeting held on the 30th of March. And if I remember correctly, Richard, you weren't here for this meeting, so we've had to rely on other people to make sure the minutes. Or were you here? I can't remember.
I was here, Philip, and I have reviewed the draft minutes, so I'm happy with them.
That's very kind of you. Thank you very much. I did say to people yesterday that you had an attention for detail that I've never come across before on a board, so thank you very much. Does anybody want to say anything about the minutes of the meeting, anything that's on them, any corrections, alterations, or anything that they want to add that's not on the agenda today? Can I therefore assume that those are a correct record of the minutes of the meeting? The action log, there is only one item on the action log, and that is now arranged for a special meeting on the 9th of June. And this is a session for the caring domain. I have nothing else down for the action log. So are you happy that I move on now to the chair's update? I've nothing to add. I haven't been anywhere exciting other than the ICS, the chairs and leaders groups. And I think I've got the West Yorkshire Partnership Board to fit in before I leave, so I shall probably end up on a high. So I have nothing more to add. Can I pass to you, Brendan, to see if there's anything that you wanted to bring to the attention of the board under the Chief Executive's verbal report?
Thanks, Philip. No, there isn't anything in particular. I think the agenda reflects the focus that we've had over the past few months, and indeed what we'll be looking to for the future. It speaks to how we care for our people, how we look after our patients, and indeed respond to our community needs, our performance, the use of the public pound, and the fact that we are in wave 6 of the pandemic, and that's a very different wave to ones we've been in previously. I think it includes, in this instance, our approach to elective recovery and how we're moving forward and living with the impact of the pandemic. As you've called out, it's the International Day of the Midwife, which is all about progress, and I think that's very timely considering our conversation around our response to the Ockenden review. And colleagues will have seen some of the news coverage of events in Nottingham. It's something we need to pay due diligence to, as something Ellen is leading us through, and we'll be discussing further on in the agenda. I think it's also important today we will cover some of this in our system thinking. You will have seen that Royal Assent for the Health and Care Bill has been granted. This speaks to, in my opinion, the most significant change in health and social care legislation in over a decade. It isn't just about the formation of integrated care systems and integrated care boards. It's also about how we deliver health and social care to the communities we serve. If you look at some of the documentation, it also speaks very specifically to care and health inequalities that need addressing, such as the childhood obesity agenda, some of the dentistry challenges that we're seeing nationally, and how we safeguard women and children in the context that we're all living in. But I'm assured of our work around us as an anchor partner and how we address some of those challenges, but it's something we need to continue to pay due diligence to. So the agenda, I think, today certainly covers off the priorities that we've been focusing on. I think the agenda remains challenging for all of the right reasons, but I think the conversation should reflect our response to date. Happy to take any questions.
Any questions or comments to Brendan? No one's indicated. Right, then we will now move on to the patient story. So I don't know who's leading off on this. I don't know which one of you is leading, but I'll hand over to whoever. Just to remind you, 15 minutes would be really helpful to us as a board today. So is it Jenny that's going first?
Sure. Yeah, I think
Thanks, Jenny.
got the presentation to share for us.
Brilliant.
Yeah, I'll share my screen. I'll share my screen now.
Thank you, Alistair. Nice to see you both.
So we've come today to talk to you about the high intensity user service, which we have. So our high intensity user service, many people will think of a typical high intensity user client being somebody facing multiple disadvantages, be these homelessness, substance misuse issues, or being an asylum seeker. While people facing multiple disadvantages are part of the high intensity user client group, they're not the majority. These comprise of many areas, from the elderly, frail, lonely and isolated people to those with multiple long-term conditions and experiencing mental health issues, and also those needing social services input. The majority of our patient population is a combination of the above. The coordination of all these services is the key. In Calderdale Community Division, we had a once-monthly meeting which had been established for some years. However, with the new management coming on board, it was soon found not to have the correct levels of governance, and safeguarding concerns were raised due to actions not being followed up and concerns being left unmanaged. With this in mind, and knowing what impact the service had been having on only a monthly meeting, a case was put forward for full-time roles to run the high-intensity user service. Within the first 2 months of being full-time, information sharing agreements, terms of references and KPIs were all established, with rough figures of cost savings for the ambulance service and emergency department combined of around £38,000. Safeguarding concerns were being addressed and other professionals were held accountable for actions being completed. The impact was clear. We were able to secure funding for another full-time role to offer support for Kirklees and to ensure equity across the trust. Governance has always been forefront in our minds. Challenging conversations with our Caldecott Guardian ensured that our consent process was robust and fit for purpose. When having conversations around consent, we discuss what is needed, who will be involved in the discussions, and if consent is declined for a full MDT discussion, we discuss then if it would be we can work on a more one-to-one basis and involve agencies on a more personalised level. This way we ensure that we're able to work with patients and ensure that we don't miss opportunities to help. Huddersfield's high intensity user group meeting was stood down for a while to ensure that we could run it with the same level of oversight and governance in place. It was important to us to ensure that we had things in correct order, but equally important to ensure that we had the equity of service. To ensure that this was done correctly, it was added onto the risk register and time was taken to ensure that we had investment and support from all relevant stakeholders. The stakeholders that we work with are broad and wide, from social prescribing teams to environmental health and back again. And the networking of these is half the battle. So we have a patient story here. So patient A was a female attending A&E and calling 999 due to renal and urinary issues. She wasn't managing well with the ongoing pain, and she had some issues with her mental health and had been deemed to be opiate seeking by emergency services. An MDT was organised and attended by mental health, A&E staff, the Yorkshire Ambulance Service and our district nursing team. From here, we organised an appointment with urology for the next day, liaised with the bladder and bowel team and referred her for intermittent self-catheterisation to help with self-management and reduce the risks of recurrent urine infections. We also made a referral into Healthy Mind service for management of pain and around grounding techniques. She's now much happier. She has a formal diagnosis from mental health services and they're titrating her medications. She's in much less pain on a day-to-day basis and has a clear plan from urology moving forward. We've had positive feedback given from her around the communication with the high intensity user service and the availability of us to discuss concerns and coordinate the services around her, and her contact with the emergency services has reduced. So the Burnt Bridges report is the locally published thematic review of 5 deaths of young men who lived street-based lives in Calderdale and died over the winter of 2018 and 2019. The impact of this has been profound and has led to new ways of working. The high intensity user group has been a large part of this. We now have a new clinic at Union Street, which is where a large portion of this patient population live. And we've had great success enabling access to health services, building trust and working with them. We've been building services that fit them using a trauma-informed approach rather than them struggling to fit into services which were never designed with them in mind. And with the Burnt Bridges report in mind, we've got a patient story to illustrate the difference that MDT working can make.
Yeah, so an example of the work being done within the Complex Lives MDT involves a service user who was a frequent attender of A&E, specifically at Colesdale, over a number of years. So between October 2019 and August 21, they'd been into our EDs 129 times, often brought into department by the Yorkshire Ambulance Service as a place of safety and shelter due to long-term issues with alcohol consumption and housing problems. Attempts have been made, multiple attempts by various services and agencies to engage with and support. However, these had not proved successful. So following the creation of the Complex Lives MDT and our support as the high intensity user service, it prompted a trauma-informed approach among services to support this person. Through intensive peer support and service flexibility, this service user was rehoused to supported accommodation out of area, which they'd been previously reluctant to do. This led to significant improvements to quality of life and mental and physical health. So one of the big recent developments within our service has been the creation and implementation of our Hiu Dashboard, which sits on KP+. So we went back through every meeting of the HIU over a period of a year and plotted monthly visits. This was to gain an understanding of the impact that we were having. Through working with our health informatics team in ED and the community, this live dashboard was created. This updates daily and it allows us to see trends while also allowing us to see costing of each visit to ED, YAS transfer and inpatient stay. The dashboard is totally unique to CHFT We've had feedback from our health informatics team that other trusts, especially across Yorkshire, have inquired about how our dashboard is working in practice. So this is just a screenshot of our dashboard. Obviously, any identifying is blacked out. This just shows an example of the main page. So it shows us how many visits per month that service users are making into our department. It refreshes on a daily basis, and it allows us to spot trends and also work proactively. So the dashboard also allows us, as I've mentioned, to review each individual attendance, so we can see what the patient has attended with, and it also allows us to look at costings to see what the impact has been to A&E and also just and to the Yorkshire Ambulance Service as well. So from this dashboard data, we've been able to analyse the visits of 49 separate service users who attended Calderdale between February 21 and December 21. We've plotted the months that they were first discussed at our meeting, and then the costings for the 3 months leading up to, and then the 3 months following our intervention as a service. And just this is some of the data that we've collected on that basis. And you can see from the impact that it's had a significant impact on a reduction of visits to A&E, and obviously the cost associated with that, as you can see from this table. So the dashboard has also allowed us to see the statistical and financial impact of HIU involvement, but it also, as I mentioned, allows us to work more proactively. So previously we were sent monthly data on service users who were attending ED 5 or more times on the 1st of each month. However, we are now able to actively engage with service users and offer our support more proactively. An example of this, a patient story from this, is a service user who'd attended multiple times at the start of March. We'd been alerted to this through the dashboard and managed to see him on the ward while he was an inpatient, and discussed at the March high intensity user group. This has allowed us to contact alcohol services, who organised a fast track assessment and organised a detox bed on discharge. We are now also able to identify service users who may not have triggered the referral criteria, but who are still attending regularly, and offer our support. So some final thoughts. One of the key aspects of HIU is having a coordinated approach between community providers, the voluntary sector, and ED and acute services. We try to offer a wraparound, holistic approach to service user engagement, and we put the person at the centre of everything that we do. And we aim to keep growing and developing our service to offer the best possible care for our patients.
So the ambition and innovation in the ways of working that we have here is clearly demonstrated above. We want to expand and move into more proactive ways of working, as Alistair said, both reducing costs and improving people's lives through true multidisciplinary team working. The reduction of health inequalities is strongly linked to the high intensity user work that we do, and we make a big difference in people's and services' lives. And to continue to do this and grow and expand in the future, we will require some further funding and resources. Thank you. Any questions?
I'll just say thank you very much for that. It's very informative. Is there Nicola, would you like to ask a question? From given your background, I would have thought this would have been of interest.
It is. I work in offender healthcare by day, so this is music to my ears. Absolutely wonderful. And I think as a commissioner in the day job as well, seeing the impact that you're making using those metrics is really fantastic, because often these projects pop up but we're never really sure, are we making a difference? So the fact that you can actually evidence it and tailor it in that way is absolutely fabulous. I just wondered whether this was happening in any other trusts, and whether you knew of, is this something that's new to, that we're doing which isn't happening elsewhere, or have you got a chance to plug into other areas, for example?
The high intensity user is by NHS England has asked that every trust has a high intensity user service of some variety. We have tapped nationally into high intensity user group through NHS England. Each trust seems to be doing it very differently. other trusts appear to be doing much more of a sort of a peer support and sort of a peer support and sort of supporting services, whereas we've taken a much more sort of robust service approach in coordinating this. So the way that we're developing our service is quite unique from what we understand, and it is, you know, quite something to be celebrated. As Alistair said, the dashboard that we have is totally unique and has been created by our lovely health informatics service with our support and input. So
I think just to come in, I think a lot of the other trusts around the country, it's run through the voluntary sector rather than it being nurse-led, and I think that's potentially what makes our service unique. It's run by two nurses, you know, an A&E nurse and a community matron, basically, our backgrounds, and I think that's what makes our service potentially a little bit more unique. Yeah.
I'm sure other trusts will be biting your hand off for that model of the metrics, because that is absolutely fantastic. I've never seen that before. And I think the complexity of working with all those agencies is to be celebrated as well, because that's no mean feat. So well done, guys.
On my list, I've got Karen to be followed by Stuart.
Okay, thank you. I just echo what Nicola has said. I think it's amazing, and the progress that you've made and the fact that you can demonstrate that progress, because in these kind of areas it's often difficult to do that. And I think I would like to certainly hear how things progress over time as well, and the impact that you continue to have. So well done. I think the question I had was around the clinic, which you said I think had just recently opened in Union Street, Halifax. Yeah. I mean, that's one clinic, isn't it? Are there plans to open up any other clinics in other locations?
Would absolutely love to do it. Absolutely love it. It's the highlight of my week, I have to say. I absolutely love my time that I can spend down there. It's just heartwarming. Unfortunately, with the capacity that we have in the service at the moment, we wouldn't be able to do any more, because it's myself and Alistair, and we are full to capacity at the moment. If we could, I would absolutely love to do that, and with input and investment in the service, certainly that was exactly what we would love to do.
We do have a wound clinic at the shelter, which is run by our matron Sarah Wilson. So her and Jane Duffy run that on a Monday and Thursday, and that's looking at so it's long-term wounds and managing that. So they do run that from the homeless shelter as well.
Okay, thank you for your leadership and your commitment. That makes a real difference, and you are making a real difference. Thank you.
Stuart.
Thanks, Philip. Really impressive. In terms of like next steps, because I was involved over in Lancashire and a similar thing. So they expanded their service over in Lancashire. So they had a similar thing, different name. I think they called it Frequent User Service, and they trialled then after that what was a wellbeing worker. So this was for the frequent users, which these wellbeing workers worked with people out in the community before they even engaged with the services. So they identified the high users and then tried to get upstream of that. And that work was peer reviewed by a university. So if you wanted any sort of connections in with that, I could connect you in with both the sort of the council that ran it with the services and then the university that did peer review, because it sounds really, really similar, but they just added that expansion of the well-being. Clearly they got funded, and it was only a 12-month trial funding period, and that would be important there. But happy to connect if that's of any benefit.
That sounds absolutely wonderful. Thank you very much. Yes, it would certainly be something that we'd love to look at. Thank you.
Alistair, followed by Andy.
Yeah, thank you for that excellent presentation, and it's I think such a good example of building services around the patient. You know, we talk a lot about this. Well, this is a sort of microcosm of that, and also partnership working, you know, in absolute practice. So a real well done from me as well. I was just going to ask about how you managed to get so many different voluntary and statutory agencies on board.
Through my lovely charm.
Yeah, well, I'm getting that as well. I mean, in terms of the funding, do they presumably the funding you talked about is the trust's funding, do they get any additional funding out of this,
No,
or is it?
no,
Or
this is
how
all.
have you
This is
managed to persuade and cajole so many different organisations who all have their different priorities and different funding arrangements to focus in this way?
I suppose it's because we work on a patient by patient basis. We do have investment from stakeholders within the monthly larger MDT, but on a more personalised level, working with individual patients, it's the services which are involved with them. So obviously they would have a want to be involved in those meetings to try and reduce the impact that that patients would have on their services as well. So we have got the investment within the larger MDT group for a cohort to be involved, but I think everybody involved with their services, it's around mutual benefit really for everybody involved. But having the relationships and the personalised approach with services as well, it's keeping those good working relationships as well that makes it easier for us to get that investment, and that's as much down to us as well.
And sorry, do they have access to the dashboard as well, presumably?
It is our dashboard. The input and the data that we can collect for the Yorkshire Ambulance Service and ourselves, that is ours. The numbers that we get for the Yorkshire Ambulance Service are through because we get the information from them as to how many times they've contacted the Yorkshire Ambulance Service. So then we've got their costings, so we can work out that. They don't have access to the dashboard because it's got patient identifiable information on it, but we will give any input, that information back to the Yorkshire Ambulance Service as well, on an individual basis.
Thank you. Andy, then Ellen.
Hi, yes, no, great story. Thanks, Jenny and Alistair. And actually, what Stuart was saying was something I was going to ask about. How do we kind of shift it further upstream rather than almost get to the frequent user point? How can we get there early? Would be interesting. Just on the voluntary sector piece, is it, as I think you've just been saying, kind of patient by patient? The reason I'm asking, I'm starting to engage in that sector, helping a couple of homeless charities. The Gathering Place and Happy Days, be two names you probably know.
Yeah,
and
very well.
And they're keen to do a lot more in health services. So is there a focal point where, because there's so many of these different charities, that brings this together for you, or is it because you're doing patient by patient, you just end up engaging with the relevant voluntary organisation?
So, from the back of the Burn Bridges report, we've got an input with the meme strategy group, which I'm not sure if you've heard of.
No.
So the meme is about making every adult matter. So off the back of the Burn Bridges report, meme were brought into Calderdale Council to have an input with them. We've got strong working relationships with Niamh Cullen, who's one of the alcohol and drugs managers for Calderdale Council, and she's sort of become a focal point really, because she published the Burnt Bridges report, and she's become a bit of a focal point herself around how we can better help and support the homeless population within Calderdale, specifically. In Kirklees, I believe we have contacts with the homeless services over in Kirklees as well, which Alistair leads
with
on.
Mission. So it's Carol Roberts over in Kirklees with the Mission, and she's starting to look at doing some similar work around a wound clinic with the tissue viability team and putting in work on that. But we're building links with Kirklees, and that's an ongoing thing at the minute.
Yeah. So yeah, Niamh Cullen is quite a sort of a focal point in herself, but in terms of the Gathering Place and Happy Days, there's so many different places, isn't there, involved? But there's certainly the meme strategy group, and Niamh would be a very good place to start.
Well, that's really interesting. No, thank you. I'll come back to you, follow up outside this actually, because I'm literally about to start some work, and I think trying to help Happy Days. And I think from memory, I've got a booking in my diary to see Niamh Cullen to talk to her. So I'll come back to you about that, because I think there's something about all the different homeless charities. Can they coordinate better together?
Absolutely.
To kind of deal with this community, which is the heart of the group you're dealing with, isn't it? I'm sure. Okay, super. Thank you very much.
Ellen, did you want to?
Yeah, thank you. I mean, I'm so proud of you guys and the service. It's good for operational pressures in A&E. It's great for patient experience in a group that don't often have a good experience. It absolutely plays to our commitment to reducing health inequalities. It shows the real value of services, community services and acute services working together. And if I can just be forgiven by the board for a partisan moment to say, on International Day of the Midwife and it's International Day of Nurses next week, we have got nurses at the forefront of this innovation. So couldn't be prouder. Well done, guys.
I would, I take that, you guys. You've done a brilliant
Thank
job.
you, Ellen.
Thank you for bringing it to the attention of the board. It's been incredibly helpful and incredibly informative. And you didn't do so bad for time, so well done. Thank you very much. It's appreciated. Okay, thank you very much. It's a public meeting. You're more than welcome to stay if you choose to, but if you want to go, that's absolutely fine as well.
Thank you ever so much.
Thank you, everyone. Thank you.
So we've noted the presentation. The next item we've got before us is item number 9, which is the Health Inequalities Update. This is from a variety of people. It's Alan that normally, excuse me, leads on this, and I don't know whether you're going to introduce this, Alan. But I mean, I'm quite proud of what we're doing for health inequalities. When I was discussing it with Brendan the other day, we realised just how much more we have to do, though. So I'll pass over to this. But it's nice to see it, and it's nice to see the indices of multiple deprivation, and it's really, well, it's good. So is it you, Helen, that's kicking it off?
It is, Philip. Yes,
Thank you very much, Helen.
No, thank you, and it's perfect segue after the patient experience story we've just heard. Taking it that everybody's read the report, just some highlights really then around the work that Anna leads on external environment connecting with communities, and we continue to work with our partners around across Calderdale Council, who've done a fantastic piece of work to look at the inequalities that have arisen as a result of the pandemic. So that's good to be involved with that. In terms of the lived experience, where we're focusing on maternity services, we've done an enormous amount around smoking cessation, which is a key clinical driver of clinical outcomes for mums and babies, and significantly increased our referrals to smoking cessation services. We're carrying on with our discovery interviews where we talk to women about their experiences of care with us, and mostly women were happy with the care but have given us some useful feedback around visiting arrangements, etc. We're very lucky that we have a public health registrar working with us, and Rachel, her name is, has identified the cultural competency training package, which we will roll out now across maternity services and eventually across the organisation. We have just appointed a mental health nurse consultant who again will be doing some work similar to that we've seen our nurse lead around learning disabilities. Continuity of care, then we have a private board paper to talk about this in a bit more detail, but 26 women have been booked onto a continuity of care pathway, and 76% of women from BAME backgrounds have been booked onto that continuity of care pathway. You'll see within the report some of the great work that's carrying on with the waiting time differential for people from BAME backgrounds and the lower IMD groups. And just to make clear, within the paper where we talk about the improvements since May, we are talking about May 2020 for those eagle-eyed amongst you who might have noticed that. We continue with our diverse and inclusive workforce work streams, and you'll see there within the report some of those areas that we're concentrating on. The report this time includes some divisional updates. I thought it was important to include that to show that this isn't just a corporate work stream, that it is getting embedded across the organisation. We have our public health registrar working on a new strategy for health inequalities because, as Philip's quite rightly mentioned, we're proud of what we've done, but there's still more to do. And we maintain our focus in terms of a national leader, and our public health registrar and a colleague from Health Informatics are attending the NHS Expo in June to talk about some of the great work that we've been doing here and our future plans. So I will pause at that point and if there are any questions. Thank you.
Thank you. Thank you very much, Helen. My indicators have lit up, so I've got Karen Heaton, Richard Hopkin and Alistair Graham. So Karen, please.
Okay, thank you. Ellen, I totally agree with you. I think this is great progress. And as you quite rightly say, there's still a long journey ahead. I thought it was really positive that we're obviously presenting at NHS Expo as well in June, I think that was, which is really good. And the lived experience, clearly it is on our Ockenden action plan. So I can confirm that. Good to see the staff training is in place, because we need buy-in across all services at all levels. This isn't something that is done to people. People have to see it for all the right reasons. And I'd just like us to encourage more use of the staff networks. I think it will be good at some point generally for the board to hear what the staff networks are doing at some point in the future, because I think constructively they have a really good part to play in what we do across the piece. Thank you.
Sorry, Richard.
Thanks, Philip, and thanks, Helen. Just to echo again, I think it's a great story. I think we know we've got some great data, we've got some great initiatives, and we're clearly a leader in this area. And I know, yeah, I've raised points previously, and we can't do everything. But picking up Philip and your point that there is more to do. I was going to ask a question around mental health, and you did mention about the mental health nurse consultant, I think that is being appointed. I guess I'm just linking it in further on the agenda. I notice in the high level risk register we've got one of the higher risks is around caring for young people with mental health issues. I just wondered whether you could talk a little bit about a bit more about what we're doing in that area, and hopefully in future reports we can see that a little bit more in evidence.
Yeah, so when the nurse consultant commences in post, I'll be expecting them to lead on the health inequalities work in the same way that Amanda has done with learning disabilities. There's obviously a link with the high intensity user as well, and I'll be asking them to map across in the same way our elective recovery programme, to work with our health informatics colleagues to map across to our elective recovery programme as well. I think it's really important that they lead on some discovery interviews to actually hear what it feels like to be a patient in our service in our service. So there's some of the key work streams that I'll be asking them to lead on, and then I think we will start to see. I mean, we need to give them time to get stuck into that data, but I think in future board reports we can start hearing the same level of detail that we do around learning disabilities for patients with mental health presentations as well. It's slightly more complex because of the way that the complexity of identifying somebody with mental health presentations as well, but that's one of their key priorities.
Okay, thanks, Ellen. That's great.
I've got Alistair next. Alistair, you want to ask a question?
Yeah, again, really good progress and well done to the team. And particularly, as Andy said in the chat, around waiting time differentials. I was going to ask, is there are there one or two particular things we've done, particular actions or initiatives that you think have helped us particularly to make that change in terms of waiting time differentials? Because I remember reading reports not so long ago where we weren't doing very well at all. I mean, we seem to manage to turn that round. So just wondered about any comments on that. And just secondly, if I may, in terms of the lived experience, we're focusing initially on maternity for very good reasons. Are there plans to look at other services in the future?
Okay, so I'll take the first point, Alistair. I think it's been, if I can use the expression clinician ignition, I think presenting clinicians with the data around the fact that there was a differential, because I don't think people would have ever appreciated there was that differential. So that's been really helpful in making people think. We've also had a process of actually speaking with individuals whose waiting time was, were waiting longer than others, and just having those conversations has really helped us, refocus in and almost have a sort of an account management style and a case management style to some of those service users. But really, I think it has just been highlighting it that has made people think and has just ignited a level of curiosity, which is absolutely great. The discovery interviews, yeah, we need to be doing that across the board. We're starting to do some work using our volunteers. Now we're opening up a little bit more. Then we're going to start using volunteers to talk to our service users about how they feel about the care that they're receiving. But you know, you've heard me say it before here, but I just felt it was really important that we got a good grip on maternity, because we absolutely know the clinical outcome of not providing culturally competent care. And again, when the nurse consultant for mental health starts, we'll have a bit more resource there, and the public health registrar working in partnership, and we'll see how the cultural competence training goes, and then we'll roll that out across the organisation.
Yeah, okay, fine, thank you.
Veronica, one of our elected governors. Veronica, you wanted to ask a question.
You're on mute, Veronica.
Yeah, I can't.
You keep coming and going. You came and went. I'll tell you what, while you sort yourself out, I'll go to Denise, if that's all right, Veronica, and then we'll come back to you.
If Veronica wants to put, if it's a question, if Veronica pops it in the chat, I'm sure either Anna or myself will be able to respond.
I'll go to Denise and then I'll come back to Veronica.
Hi, Helen, thank you so much for the report. And it's, you know, again, it's another encouraging update on where we are. And as already been stated, this is a piece of work or an area that's never going to end, is it? It's just that we move on to other areas that have been identified. And as you've mentioned, there's a heightened degree of curiosity. For me, one of the things that popped out of this update report is around the increased DNA rates, that it's higher for more deprived areas. So for me, this is an important area, isn't it, for us to investigate and to understand, because perhaps we're going to have to change the way we communicate with patients from these areas, because of course, if we've got increased DNA rates, it impacts, right, doesn't it? It just causes us problems elsewhere. So do you have a feel of in terms of the interrogation, what kind of approaches are going to be used to look at this?
Yeah, so some of the early conversations with some patients who DNA, it does seem to be related to work commitments, Denise, and people on the lower end of the salary scale finding it very difficult to come out of work. So I think that's really important. So where we need to focus on it, if that's the reality, which it clearly is, how do we then give people enough notice, or how do we support people who, you know, how can we support people in those circumstances, I'm guessing, and how do we communicate with communities to understand the importance of not DNAing, both on their health and on the you know, the best use of resources for the services in their area. But more to do certainly around the DNA piece, and that will be on our strategy and our plan for plan on a page going forward. Thanks, Denise.
Thanks, Denise. Do you want to have a try, Veronica? Veronica, what I would suggest is, because we can't hear you, is if you contact me outside of the meeting, or put something in chat, or contact Alan direct, and we will do our best to answer your query for you. We have a governor's meeting next week, so if you did it tomorrow or on Monday, we could probably get you the information by Tuesday. So thanks very much, Veronica. Has anybody therefore got any other questions or comments to Ellen, who's done the presentation, well, the discussion, and we're asked to note that, okay? So we move on having noted that. Now, for those of you who've got an older agenda, there is an additional paper that Anna is now going to introduce, which is regarding our relationship with Kirklees Council. And this paper needs to be approved. So Anna, it arrived late, apologies for that, but we need to get it before a board meeting in order to fit all the time frame. And when I discussed it with Brendan, we thought we should at least try and achieve it. Apologies for it being late. I'll hand over to Hannah at that point.
Thank you, Philip. As referenced by Brendan in his introduction, the West Yorkshire Integrated Care System has been progressing work to implement the legislative changes that are set out in the Health and Care Bill that will see the ICS established as a statutory body from the beginning of July. This is a welcome and important step to strengthen collaborative working and partnership across West Yorkshire. In preparation for this, the Trust has been working closely with system partners in Kirklees to develop plans to establish a subcommittee of the West Yorkshire Integrated Care Board. This local subcommittee will make most of the decisions about services, planning and developments and spend in Kirklees going forward. And the attached paper sets out the collaborative partnership agreement that has been developed, and it's presented today with the request that the Trust Board formally agrees that we sign up as a partner member of the Kirklees subcommittee of the West Yorkshire Integrated Care Board. Thank you.
Are there any questions or comments? We have a similar agreement with Calderdale. Can I assume that everyone approves this as the way forward? It'll be up to Helen and the rest of the board to work out who they ask to attend going forward. Thank you very much indeed. Appreciate that, Anna. Thank you. Sorry, I will go to Gary now. Thank you.
Okay, thank you, Philip. So the next paper is the annual plan, the financial plan that we're asking the board to approve in this meeting. So what I've included in the pack is the full budget book, and there's lots of detail in there that has been discussed thoroughly at Finance and Performance Committee and has been discussed previously at a high level at the previous board forum. I don't intend to go through in much detail, but there are just one or two bits and pieces that I wanted to bring to everybody's attention. So the final financial plan that was submitted last week shows a 20.1 million deficit plan for us as an organisation for next year. And if you recall, that's around a £3 million improvement from the previous plan that was proposed at draft stage. That deficit plan is a plan that we're proposing, which is after delivery of £20 million worth of efficiency savings, plus a further £5 million worth of COVID costs. So around 5% efficiency that we need to deliver still leaves us with a £20 million financial challenge for next year. Other points to highlight that I've said before, but are really important to call out really, is that this plan delivers 104% of the 1920 activity levels, which is a requirement, and then will support our patients and work on improving our waiting lists and caring for more patients. There are a number of risks that we flag. You know, as an accountant, typically I will flag some of the risks within our financial plan, as I always do, including assumptions about the levels of COVID activity that will take place next year, and also significantly required improvements on the number of patients that we've got within our beds for delayed transfers of care. So the overall financial plan itself, it remains really challenging. And just to say that we are still being challenged by the ICS, the care system, on that plan, and challenged with a number of deep dives taking place. And there is an expectation over the coming period that we work to try and improve that financial plan. So that work will continue. And the only other thing that I really thought was worth calling out, which is presented in a little bit more detail in this paper than what you've had before, is the capital plan. So what you can see within the pack is that we're intending to spend £39 million on capital next year, of which 17 million is our internally generated funds, and the other best part of 23 million is funding really around supporting reconfiguration, scan for safety, and other sources of funding that come in. So that's the plan. Don't intend to go through any more detail. I'm happy to take questions, but it's brought here for approval, please.
Just trying to work out who went first. According to my notes here, it's Richard first, followed by Karen.
Thanks for just to reiterate as chair of Finance and Performance Committee that this plan has been thoroughly reviewed over the last 2 to 3 meetings. So we spent a lot of time on it. There is a lot of detail, excuse me, as Gary said, in the budget book and in the board pack. Just to re-emphasise, clearly it is a significant challenge for us for 22-23, both operationally and financially, and there are some risks attached to it. On the positive side, I get the impression that both the operational and the management team as a whole are up for that challenge, and certainly we've made a good start in terms of the identifying and progressing the efficiency savings through effective resources group, etc. But nevertheless, clearly a significant challenge going forward. That was all I wanted to say, Philip.
Thank you very much. Karen, you're next. Karen, please.
Yeah, I mean, this is a significant challenge, but we're in a very turbulent world at the moment with higher and higher inflation potentially, and more difficulty for lots of people, but obviously for prices and so on. And this is just a general question, Gary. I mean, are you doing some modelling to look at the impact on, because it is a challenging target, this, but clearly if the turbulence, you know, ratchets up, then it's going to be even more difficult. So I was just wondering if you are doing some modelling about potentially what that inflation could be and the impact on that deficit.
Yeah, no, it's a good question, Karen. So within the funding uplift that we've been given, there are certain assumptions about the level of inflation, and we know that they're running at significantly higher levels than we're in the funding uplift, which is contributing towards our challenge, really. So of that £20 million challenge, we're able to identify how much of it is driven by inflation running at high rates. This is a piece of work that's been done right across the system. Different organisations have got different challenges. So, for example, organisations with significant PFI contracts, they're feeling the pinch more so than some of the other areas. We're all feeling a struggle around energy, so energy prices have gone up by more than was suggested in the inflationary uplifts. And there are some other areas. So at Finance and Performance Committee earlier this week, we approved a paper around our sterilisation, clinical service sterilisation, HSDU type costs. We've been negotiating with suppliers, but we end up with an inflationary uplift of around 13% on that particular contract. That's after negotiation, yet we know that the standard uplift was significantly less than that. So of our £20 million challenge, you could argue that broadly a third to a half of it is around inflationary challenges.
Yeah, okay. Thanks, Gary.
Okay. Any other questions or comments to Gary? We're asked to approve this. Lots of other places are facing similar challenges from what I've been able to read. Andy?
Sorry, yeah. So Gary, no, thanks for that. I had a variation on Karen's point, really, which is there's kind of national guidance, isn't there, assumptions through some of this, which already may look challenged. Are you getting any sense kind of from the centre or even ICS level how they're likely to treat that? Or is it, you know, it is what it is, you've been given the assumptions, you have to work to it and it becomes our problem? And then the other question I just had on the risks, clearly we've got the 104% activity levels and the DTOC at 70. On those, does the plan assume they're achieved throughout the year, or we get to a point and then achieve them?
So just on that last point, the 104% is the cumulative position at the year end. So it is a phased approach, and we know, I think we've presented previously in other forums about how we are able to gradually improve and ramp up elective activity throughout the year. So that's how that challenge plays through. I think you're right to flag this. We're not unique in having this particular challenge. Each ICS has had to submit its version of plans, and at the moment the NHS does not have a balanced plan. That's not to say that that's going to be accepted or is acceptable. I think everybody has to work through those, and there is further challenging discussions ongoing about how you drive those down. I think at the centre they recognise the inflationary challenges and recognise how tough it's going to be, but until more funding is secured for the NHS, if indeed that's possible, then it remains a problem that we've been tasked with resolving.
Okay, yeah, I'm not surprised. Okay, thank you for that.
Brendan, you want to say something, please?
I think it's probably to Andy's point that the NHS has had significant investments, but our financial position has been a problem for a significant period of time. The message, Andy, is clear. We need to get to a break-even position. I think Gary and I and colleagues are in it. We need to be realistic about this, and what we need to think about is a pragmatic, reasonable, phased approach to getting to that space that can't just be about CHFT. It has to be about how we work in partnership across both of the places that we serve. And in amongst this, I think there's the whole debate around the impact on quality of services. This organisation does have what I consider to be a robust EQIA system, which is an equality impact assessment around this, and I think that's something we should continue to pay attention to going forward. With a trajectory and a target of this size, we shouldn't underestimate the impact going forward, but we will get to the point where we need to consider what some describe as unpalatable, some describe as higher risk initiatives, but we will be in that space going forward. I think probably to your point, Philip, as will the rest of the country, based on Karen's description of the turbulent environment we're operating in.
Thank you for that clarification, Brendan, and thank you for your presentation, Gary. This is a paper to approve. Is the board happy that this is what we do to approve this paper? Thank you very much. The next item I have down on the agenda is a recovery update. And this is to note, and I've got Joe down for this, according to my notes. So Joe, can I hand over to you for the recovery update, please? I might have lost Joe. Gary, can we just move down to the 12-month 12 financial summary while we try and get Joe back on? Gary? Can we go down to month 12, please?
Yeah.
Thanks for helping me out, Gary. Sorry to catch you unawares a bit.
No problem. I was just shouting across the office to Joe to tell us he was on mute. Yeah, so this is the month 12 financial report, and it's brought here to note. So what the report shows is that at month 12, we've delivered a surplus of £40,000. This is all subject to audit, and external audit are with us at this moment in time. Just to note, and we do flag this in the paper, that when we see the final accounts over the next month or so, the final accounts will show a 300,000 deficit, and that's due to technical impairments. Nothing unusual in there, but from a monitoring purpose point of view, we will be showing a £40,000 surplus, which is deemed a success from our regulators and our ICS. I won't go into much detail, but really just wanted to flag that overall it's a strong financial position. It's quite a positive report. So we'll have delivered our overall I&E position. Our agency spend is within the trajectory that we were set. Our cash levels, we closed the year with higher cash levels than we planned, which again is good news. I know on the dashboard it flags that our capital expenditure was higher than planned, which it flags it as red, but actually that's good news. It means we've spent more on maintaining our estate, developing our services, and just to give some assurance that capital expenditure was agreed during the year. It's not an overspend as such. It's just that the plan doesn't get revised by regulators. And then overall, we've got a use of resources score. So whilst that hasn't been monitored for a number of years now by our regulators, it is something that Finance and Performance Committee still hold me to account on, really, make sure that we're making the right movements and progress. And again, we closed the year with a use of resource score of 2. So wasn't intending to say anymore. This is brought to note our final year-end position, which is quite a positive position, but happy to take questions.
There are Peter Wilkinson wishes to ask a question, followed by Alistair and now also Tim. So we'll run in that order. Peter, Alistair and Tim. Thanks, Gary.
Thank you, Philip. Thanks, thank you, Gary. Yeah, I just wanted to say we went through this in quite a bit of detail at Finance and Performance with Gary and Richard and Philip. Obviously, you were there last week. No, not last week. This week, Tuesday, wasn't it? Seems like a lifetime.
This week.
This week. And I just wanted to say what I said actually on Tuesday, that I think this is as Gary said, a really positive position. Real credit to Gary and the finance team, which I think should be acknowledged and recognised, particularly given the challenges and headwinds that have been with us over the last 12 months and will continue to be so. So I just wanted to make that point. Thank you.
Well, I think also, Peter, it was well received at F&P, so I think it'll be well received again at this meeting. So thank you. I've got Alistair to query next.
Well, Peter's largely stolen my thunder, actually. I think very similar points. I think given the challenges that we were faced with even just 6 months ago in terms of H2, I think this is a really great credit to the organisation that we managed to deliver a break-even position. Clearly, the elective recovery fund bids helped. So again, well done on submitting those successfully. And I'm also delighted to hear about the capital programme charging ahead and delivering the much needed improvements. So well done from me.
Tim, you'd like to ask a question or make a comment, please?
Yeah, it was just again echoing that that's great to get that cash position, you know, despite the increased capex. But I did notice in the notes there's something about a 5 million adjustment deferred to next year. Would you be able to just explain that and why that's next year?
Yeah, I mean, this it'd probably be worth picking this one up outside of this forum, because it's quite a complex technical adjustment. So it relates to potentially some of our reconfiguration and a potential write-off that was hopefully we were planning to progress during the year, but we can pick that up outside if that's helpful.
Sure. Yeah, thanks.
Sorry, Nigel, you wanted to ask or make a comment?
Thanks. Obviously, I'm relatively, very new to this, but recognise from kind of my background, there must be some enormous credit there to the fact that, you know, to bring it in within 40,000 of the plan is some achievement, given the uncertainty that there's been everywhere in the public sector over the last, well, not just 12 months, years, to be frank. It's really just a question, probably driven by my lack of understanding at the moment, is in terms of the additional funding that came in that covered the shortfall in the efficiency savings requirement in the previous year. Is that an issue for the current year now, or does that disappear, that problem? So do we start from scratch again in terms of those efficiency requirements, or does the shortfall from last year have any impact upon the current year's plan?
It's a good question, Nigel. So the efficiency challenge that we had is a recurrent challenge every year, and the fact that we were unable to identify the savings recurrently does contribute to our challenge that we've got this year. I think what we've done very well this year is working with partners and as a system has been about how as an ICS we get over the line together, how we work together. Obviously everybody else is conscious of their own positions this year, and further conversations, I think, as Brendan alluded to before, this is about how we work differently as partners now within this year. And that, you know, so whilst we've got a £20 million deficit plan, actually that's a challenge for the Kirklees place, it's a challenge for the Calderdale place. It's how we do something differently to reduce our spend, whether that's reducing it in the acute setting or in the hospital, in the places, community places. We've got to work collectively on covering that.
Thanks.
Are there any other questions or comments to Gary? Tim, you've still got your hand up. I presume that's you might want to take it down. Is that all right? But do you want to come back, Tim? Oh, thank you. we're asked to note and assure this. Are you happy that that's what we do? Thank you very much. I understand, Joe, that you've run across the Agile work area, probably aptly named, and that we can now go to the recovery update. So thank you for making that swift journey.
Can you hear me now?
I can hear you now, yes.
Yeah, thanks to Andrea. I've swapped PCs temporarily. I'm just back from leave today, so the Teams update has clearly not worked on my laptop this morning, so that's great. So just some salient points, as you said earlier, Phil, about the paper. So in terms of recovery, you will see in terms of our work against the P2s and P3s, there's still work to do around our P3 patients. But we've made good progress in P4s and reducing our open pathways, and significant progress against the 104-week trajectory, as I've spoken about before. I just want to draw everyone's attention to the echo and neurophysiology slides. We still have significant problems around echo diagnostics and neurophysiology diagnostics. We are using external companies to support both diagnostic standards, but there is some good news in terms of recruitment into echo posts going forward, and we've just started a West Yorkshire review around neurophysiology and neurology, which won't solve the short-term issue, but hopefully will provide a medium to long-term solution around neurology and neurophysiology. We are making good progress against the MRI trajectory and clearing the backlogs. I'm really pleased about the progress that the operational teams have made against that. And as many of you have heard me say before, we have a significant plan around follow-up backlogs, and the follow-up numbers have started now to come down, but there is a lot of work to do around follow-ups across all services in the trust. The other thing I would say about echo moving forward is the work around the community diagnostic hubs, which is really reaching some significant points now. And with the cardiac network as well involved in echo, we're looking at echo solutions across the network. And it is also forming part of elective improvement and recovery conversations as well with our GPs and community partners about how we manage echo referrals and pathways moving forward. So those are key things I just wanted to highlight. Philip, happy to take any questions.
Are there any questions or comments to Andrea? Andy?
And so Joe, even. So Joe,
sorry, I came up there. I'm sorry, apologies.
Confused us all. Sorry, where was I? So just one comment. So I joined kind of the more detailed recovery meetings, so just to share with the board that been more work being done in KP Plus now around a set of models, which I think Joe will talk about, which I think is really good. Some really detailed modelling of how do you get to 104% and tracking that almost on a day-by-day basis, which I think is really good to see and will help. And when I've asked the health informatics team, that's actually driven some much more use of the knowledge portal in terms of that. So it's great to see. Just questions, Joe, on the 104 and 78, you know, these longer waits, we were coming under pressure a little while ago from regulators around we were an outlier, even though I was frustrated we were a positive outlier on things like P2s. Are we now in line with their expectations on those longer waits in terms of trajectories we've set? And then my second question is, we did touch on the recovery meeting. I think I understood it with them. I just want to check. We see those earlier graphs, P2s and 3s. The trajectories in there are ones we set a long time ago. Are we intending to reset those on back of detailed plans? So in future board meetings, we look at a different trajectory that, because the obvious question when you stare at the moment is, hang on a minute, we're a long way off where we want to be. And I don't think that's right.
Yes, we will reset the trajectories, Andy, and we will look at those through a different lens. And as you said at the recovery meeting, we're building those dashboards and models now to do that. In terms of our regulators, I think there is still nervousness across the whole system around the 104-week and 78-week position for this year, based on some of the risks that Gary referenced earlier around COVID numbers. We're still seeing COVID sickness, and for us, we are still losing some of the theatre capacity because of sickness, which will impact on the volume of work we can do. But I provided assurance to NHSI before I went on leave around our trajectory around 104 and 78 weeks. But we have a weekly meeting with NHSI to look at our recovery position and our backlog numbers, and we have a daily meeting around all our patients that are on those trajectories, on those waiting times at the minute, just to check that those patients are still coming in. And we talk to those patients regularly, so there will be significant focus on this as we move through the next 2 months. The absolute deadline around 104 weeks is the end of June, and what NHS are talking to us about is any patients that might cancel or choose not to come in for TCI, and then it's about our ability to get those patients back in. So we've almost got scrutiny around individual patients as we move forward.
Okay, so that gets us in a better place than where we were before, I guess, from their perspective, which is good. Okay, fantastic. Okay, good stuff. Thank you.
Are there any other questions or comments to Joe? And apologies, Joe, I just saw the name Andrea. I do apologise.
Yeah, that's fine. It's confusing.
Any other questions or comments to Joe, please? Because we're asked to note the recovery position, and it's okay. Thank you. I'll now move down to the green plan, climate change, and I've got Stuart down to bring this to our attention, and we're asked to note this green plan. So, Stuart.
Yeah, thanks, Philip. Yeah, the paper today is for the board to note, and it gives a progress update relating to our green plan and the sustainability action plan. You'll see from the papers that there were 191 actions proposed in the plan, and it's good to report that 110 have been complete, and that's set out on page 3, figure 1. I'll just highlight a few key actions and progress, which I'm sort of pleased to note. So Yorkshire Audit have looked at us, and they've confirmed that the trust is demonstrating a commitment to minimising its adverse impact on the environment. Also, we've made an application for SALEX funding, which is, if successful, that would finance air source heat pumps, solar PV, etc. at HRI and at Calderdale. Again, in terms of our biodiversity action plan, I'm really pleased that was approved by the Transformation Board recently. We have made some progress in terms of LED lighting, which clearly is important given the rising cost of energy that everyone's familiar with. So that work is starting at Calderdale, and it's almost complete at Huddersfield, and it's already making significant energy savings and money savings. Again, as reported previously, we were asked to have a net zero lead at the trust, so I put my name forward for that. And I also represent the trust on a number of different climate boards. So, for example, as a climate commissioner at Kirklees and the WIAT Net Zero Committee, which I'm on that board. So not everyone was here at the time, but the green plan was first approved way back in March 2021. That does seem a long time ago now. And we monitor progress through the Green Planning Subcommittee, which Andy chairs. The Green Plan is a board-approved document, and that's submitted at ICS level. And there, as I say, there are various themes which we describe in the subsequent paragraphs and give reports. So given the time constraints, I won't take you through each theme, but I'm sure hopefully you'll all have noted that we've made huge progress since we last came to this. And I'll pause there should Andy wish to add anything, or if anybody's got any questions.
Any questions or comments? Andy, you wanted to draw something to our attention?
Yeah, just to add, I think I'm very pleased with the progress that's been made here. I think it's a really good story. There's some other things you could add in the list, can you, Stuart, around travel we've done, where we got the fleet now with the trust in terms of the use of vehicles. So there's good stuff in there. I think a couple other points to make looking forward. So the green plans come out at an ICS level. Stuart and I are pretty confident that our plans well align with that. You've seen it, Philip, the ICS kind of level green plan as well. So I think we're in a good place there if somebody came to challenge us. And then the challenge I've raised with Stuart and the team now is it's great to have 110 completed tasks, if you like. How good a job are we doing of actually measuring the outcomes of those tasks? Can we really demonstrate in travel, for example, we're making great use of the revised shuttle service. Can we see our carbon footprint coming down? So we're now doing a piece of work to come up, if you like, with a green plan dashboard, reusing where we can what the NHS has as a greener dashboard. They have one. We'll reuse some of that, probably add some other measures into it. So that not only can we say we've completed some tasks, but we can show the measurable outcome of that. So we go back to the patient story earlier, that there was that great stat, wasn't there, on admissions to A&E. It's trying to do a similar story. Can we really show in the outcomes that we've made the difference, all the complete tasks? So.
Alistair, I want to make a point, but you might make it, so I'll let you go first.
I was first going to thank Andy and Stuart for their leadership on this. I remember when this came to the board a while ago, and it's great to see so much concrete achievements that we've been able to make since then. I was going to ask a question actually about charitable funding. So I think that we're making a bid, or have made a bid, for charitable funding around landscaping the area where the old nurses' accommodation was demolished. Is there scope to increase our charitable bids, if you like? I noticed that some of this is dependent on external funding. We put a bid in for Salex funding, I see. I'm not sure what the outcome of that's going to be. But certainly some of the things we want to do under the Green Plan, I would have thought, looking at it, would be eligible for potential charitable funding from our own, the trust charity. I don't know what further thinking there is around that.
Stuart, do you want to come back on that, or Gary might want to make a comment?
Well, in terms of the funding for the work that we're doing at HRI that Alistair mentioned, yeah, we did put a bid in, and we were successful. I think we've got 80k, which we'll be using. If you can imagine where the old nursing block was, which was demolished there, so we'll so as part of our biodiversity. So we've had a number of successes. So we've successfully got some tree saplings, which hopefully will be coming in November for more biodiversity. And then we're creating this, as I'd like to describe, like a well-being area for staff to sit, relax, particularly when it's not raining, to sort of be able to use that area. So, but you're right that I'd like to think there are more opportunities internally for charitable funding, and we're always on the lookout for external funding opportunities, because we've got high level of ambition, but there's not always the money there. So just as another example, following up from Andy and where we were to where we are now. So in terms of our fleet, 94% of the trust's fleet is now electric or hybrid. And when I give that figure to sort of other organisations and councils, they're amazed, and they want to know how we got there and how we did that. So I think it's a good journey that we've been on.
I've got Karen and then Denise.
Yeah, thank you. I think it does show our genuine commitment to this agenda. So really well done to everyone and the progress that you've made. And it gets harder and harder, I think, to demonstrate progress. But Andy's answered one of my points, which was about how do we actually demonstrate what that difference actually is in hard measure. The question then I had was around how we getting staff engaged in this agenda, because this isn't something that, we just have initiatives. We actually want people to be committed to this agenda, know what it is, and be committed to it. So my question is, how are we actually getting staff engaged in this?
If I could come back, Philip,
yeah, please do. Yeah.
Yeah. So I mean, in lots of different ways. I'll just give you an example, just in terms of waste. So we send out our staff. So Nigel, for example, goes round to both sites and talks to them about waste and waste streams, and sort of where to put it, but also the benefits of putting it in the correct waste stream and the financial savings that it does. So we were thinking about doing a video, but then we actually seem to be having more success, and it's a slow burner, but that's one example. And then we'll speak to porters and have that conversation with them, and that's part of the education. We do lots of comms. We speak to new starters. We do quite a lot of work there, but I think it's that face-to-face it's having a big impact, in my view.
Do we have local green champions?
We do,
yeah,
and we've got some posters up and around, which is really good. We've got the Green Planning Committee, which Andy chairs, and I'm also in attendance to that. And it's hard work getting people to attend meetings because everyone's so busy.
Yeah.
But we're getting a good and better spread, I feel, of people attending those meetings, and they're selling it. So rather than just listening to Andy and me sort of pap on, I think they're then going back to their teams and saying, these are the reasons why you need to do it, or if you want more information. So I when I've got what the actual, I think it's a grand tour or something involving our clinicians, and I gave a presentation to all our doctors, and again that really got a lot of interest there. They weren't aware of so much that we do, and that will lead to sort of further conversations with them.
Okay, thank you.
Next, I've got Denise.
Stuart, thank you. This report, I really enjoyed reading it. It's a great report, and it's so good to see the advances that have been made since the last time you presented the work to the board. Just what Karen's asked one of the two questions that I wanted just to flag with you. So what's interesting, I read an article, I stumbled across an article recently that was really an advert, but it was saying that hospitals can be clean and green, and I'm just wondering how much progress have we made in terms of looking at kind of cleaning materials and those kind of things that we're using around the sites.
And sorry, a dangerous steal in the show here. Sorry, Philip, but it's a constant of interest to us, that particular issue. So and it's not just sort of the cleaning, but also in terms of weed control is something that's really close to my heart, and not using chemicals. So absolutely, and sometimes I think we're probably ahead of where we of the market in a sense. So perhaps the market needs to catch up with some of our ambitions. I'd give that an example of like the shuttle. So we're really keen to go all electric for our shuttle, but it's not quite there yet. So we had to get hybrid vehicles. But you're absolutely right in terms of cleaning, and it's something that we're constantly monitoring with the facilities team to look at different products, just test how they work, and then obviously the cost.
Thank you, Stuart.
And I'll assume yours is an older hand and go straight down to Tim.
Yeah, some very impressive actions in that Stuart. Does the green plan focus purely on internal, on the trust, or are you looking to also extend it to the supply chain?
Yes, it absolutely does look at the supply chain, and that's sort of a key part, and that's where we link with procurement and our sort of social responsibility. So as an example, where we in catering, we really are looking now. We run catering at HRI where we can buy local. So it's both good keeping the money in this part of the world, but also it just the miles. It's just good on every particular level.
Right. Okay. Thanks.
Karen, you went away and your hand was up. Did you want to say anything, Karen? Again? No? Okay. Denise, yours is an older hand, I think. I just wanted to say two or three quick things. A challenge to you. It seems a bit strange to me. You can get on a shuttle bus, but you can't car share. I just think we should have a look at that at some point. There's a scramble in the morning when I come in at 7 sometimes for the electric vehicle charging points. Brendan sits there smugly because he's got 300 and odd miles on it. Some of us haven't got as many miles as Brendan. And just to say big up on the self-closing bins, because I know just how much effort you put on personally with the self-closing bins and how that improves patient sleep. So just some comments for you, and thanks once again for your report. Because we've fairly gone at it fairly quickly, what I would suggest is that we have a 10-minute break for you to be able to have a cup of tea and do whatever it is you want to do in 10 minutes. But you are back, please, at 25 to, and I will start then on 25 to, and we'll come back with a workforce and organisational development strategy, including the staff survey, and we're asked to note that when you come back. So thank you very much. I'll see you when you get back in 10 minutes. For a cup of tea, lad. Tea. You've reappeared, Joe, with your name on the bottom of the left-hand side. I can't hear you though, but
Joe. There it is. We can hear you now. Nope, we lost you again. Heard you giggling for a second.
good morning, Christine. I didn't realise you were there, but nice to see you, Christine.
No, can't.
No.
You got the right microphone. So
That was it.
Yeah.
There you go. We can hear you.
Oh, you're back.
Can't hear me on the main mic though. No.
Yeah. Well, I think we're all back. I don't think anyone's had a better offer, so we will now move to the workforce organisational development strategy, including staff survey results and action plan. Suzanne and colleagues, we've allocated about 15 minutes for that. I hope that's acceptable to you.
That's great, Philip. I do want to go through in a little bit of detail today about the staff survey response.
I can understand that. That's fine.
Yeah.
But don't worry if
No,
you're
it's
running over.
important to us, and also in the Sheffield CQC report, there was criticism about the lack of detail understood by the board on staff survey. So thought it was important to go through this today, and also to look at our commitment at the end as a board in terms of how we're going to help improve staff engagement and morale at CHFT. So Amber's going to drive the slides for me. Thank you, Amber. So if you go on to the first slide. So it's all change again, I'm afraid. So in 2020, we had a change to the group that we were put in. So we are now benchmarked with acute and community hospitals. It makes it a little bit to distinguish which are the community results and which are the acute. So bear that in mind. And then last year as well, so these results that we're going to discuss today, there was a change in that they're now put under 7 key people promise scores. And those people promise scores are the 7 promises made in the NHS people plan that was approved improved last year. Overall, a very disappointing picture for the NHS, a decline nationally in most of the scores, but a steadiness in terms of the response rate. Next slide, please, Amber. So in terms of CHFT, we got 3 more actual numbers of staff survey responses than last year, but as a percentage, that equates to 48%, which is just slightly down on the 50% that we got the year prior. Our engagement score reduced from 6.9 to 6.7, but remember, there is a little bit of a change, so we have to just look at that with some element of caution. And the things I just want to draw your attention to is some of the things that we need to improve. First of all, we'll go on to the positives, of which there are many later, but to begin with, these are the areas that we will really need to work on. So common themes for improvement, definitely effectiveness of appraisals, which is disappointing because that's come up for the last few years. There's evidence in our staff survey responses of burnout, stress and frustration, as there is nationally. And if there are 2 key areas that require our support, that's our PMU and our medicine division. Our nursing and midwifery colleagues, their engagement score reduced by 0.3, and then you'll see some of the areas in the directorates below, orthopaedics and women's in particular, that saw quite a dramatic decline in their scores last year. I think for all of us that were here at the point that the survey ran, it will be no surprise to you when I take you through the scores, both for CHFT and the national NHS. One thing to bear in mind, however, which is really important, is that if staff engagement is all about improved patient outcomes, we must remember generally scoring higher than most Wyatt trusts and very high up in the leaderboard of A&E performance, and also our cancer responses, which are very positive too. So if we go on to the next slide, please, Amber. So as I said, there are 7 people promises. They now look at morale as opposed to staff engagement. We've mapped staff engagement over, and you'll see that like for like, we had a decline in our engagement and morale from 2020 to 2021, not surprising. Next slide. There are some positives, which we'll come on to in a moment, but we do have quite a bit of work to do on ED&I. Going back to the health inequalities piece that Ellen presented earlier, we now break down all our staff data in terms of the health inequalities, the IMD, Index of Multiple Deprivation, so that we can see which groups are most engaged and are least engaged across the trusts. So in terms of ED&I, we've still got work to do for colleagues with a disability, colleagues who are LGBTQ+, colleagues who are aged 21 to 30, and our white colleagues who scored 0.3 lower on average than our BAME colleagues. Next slide, please, Amber. On to the positives though. So amongst all of that, and we've got to take that on the chin and listen to what our colleagues have told us, there are some amazing positives in our results. So my organisation takes positive action on health and wellbeing, saw a huge increase, and we are above the national average by about 3%. Those trusts that came to see us about the wellbeing hour, about our health and wellbeing risk assessment, have contacted us again about these scores. And I think the message that we're giving out is that we've paid a lot of attention to it. And I think every member of the board will reflect just how much effort has gone into improving that score. Also, what's very pleasing is opportunity to show initiative. It has increased and is above the national. There's something very positive in terms of our increase, but more work to do on immediate managers involving colleagues in decisions that they make. Particularly, I think this is really important when we look at other workforce health indicators. Colleagues feeling secure to raise concerns about unsafe clinical practice is above the national score and has increased during a very difficult period of time. We did some interviews last week, and a colleague from another trust told us that a lot of their concerns go straight to CQC. Whilst we have a high number of concerns at CHFT, they come to us, and that's a real indicator of colleagues trusting us to do something about the things they raise. Always knew what responsibilities are. That may come from a bit of the command and control we've had to put in. That's above the national score. I think there's thanks and congratulations to the community who scored better than average on 8 of the questions, and overall the work that's gone in through ED&I to the BAME network and other actions has seen a positive increase. And as I mentioned earlier, BAME colleagues feel 0.3 more engaged than our white colleagues. Next slide, please, Amber. I've put on this slide for you to just look at some of the detail in terms of those scores where we benchmark highly and those scores where we've got work to do. Just to point out, if we go to the next slide, Amber, please. The scores and the questions where we scored the least and declined the most are the same questions that nationally declined the most. And if you read some of those questions about looking forward to going to work, being enthusiastic about your job, enough staff, didn't come to work when didn't feel well, they are the questions that obviously were impacted by high COVID inpatient bed base at the time that we carried out the survey last year. And that is no excuse. However, we all know that our bed base was very high, and certainly across West Yorkshire it was higher than other parts of the country, so we do have to be aware of that. Disappointing that our the scores to our question would recommend a place to work decreased, and they decreased by quite a lot, so there is lots more to do. Next slide, please, Amber. Something else that's important, and we're going to map over a couple of those performance scores that I mentioned earlier, which is the A&E performance and our cancer targets, because we can only look at our engagement scores when we compare them with our performance scores. I can't, as a workforce person, sit here and say that, you know, good engagement gives high performance if we're getting lower than average engagement and not getting high and getting high performance, and we are. So whilst we have declined in our engagement score and we're not the best across West Yorkshire, we're certainly the best in terms of our A&E performance and our cancer targets. All trusts across West Yorkshire declined by at least 0.2, and you'll see in there that Leeds and Bradford actually declined by 0.3. Mid York stayed the same at 6.6. They carry out their survey a little bit differently to ours, which is more targeted. But we are working as a group of HRDs to look where we can learn from some of the things we've all put in place, and across those 7 people promises, where do we each score higher and what support can we give to each other. Next slide, please, Amber. So our key priorities out of all of this as themes are one culture of care. We have to keep on with one culture of care. Wellbeing, even though we scored very highly and improved, we have to keep on that. We have to keep our colleagues going. We need them to be very honest about their ability to carry out their work safely, and they are with us. We need to continue our work on work together, get results and change and improvement. Authentic speech is something that's come up in the listening events that we've been holding on the back of the staff survey score, which is that people showing poor behaviour aren't tackled. So that is something that we definitely need to do. We're working on our appraisal, and this will come up a couple of times over the next couple of slides, but leadership visibility is absolutely key. People want to see us, they want to see their leaders, and they want to see us out on wards and in services and departments. And inclusion and teamwork, we need to improve those scores for our colleagues with a disability, LGBTQ+, and also our younger colleagues. Next slide, please, Amber. So we've put together a couple of strategic pieces of work. So in terms of our questions and our engagement, we've now engaged approximately 400 colleagues on this piece of work. We had some feedback that people were getting really confused between one culture of care, the 4 pillars. What were our values? What were our behaviours? And so we've spoken to 400 colleagues, and this is what has been the product of that piece of work, where we have merged our values and behaviours together under one culture of care. That's important because when we ask our colleagues what their values are, they don't always know what they are, but if we ask them what our 4 pillars are, they're able to recite them. What we need them to do is understand them, not just recite them, and then to live and breathe them. So this is a piece of work that is now being rolled out across all services, wards and departments. It's an idea that came up through Medicine Division, David Britton. I've got to copyright it to him, but each service, ward and department is now taking this, and they're doing their own version of one culture of care and 4 pillars and what their values and behaviours are to each other as a team. And then the next piece of work, next slide please, Amber, is our people strategy. So we launched our cupboard about 7 months before we went into the pandemic. It was of a time. The time has now changed, both in terms of tone and the issues and the activities that we've got in our people strategy. So the people strategy, the cupboard, is under a review at the moment. We are engaging colleagues. It is another bottom-up exercise, just as we did with the cupboard when we did that 3 years ago, but it will be very closely aligned to the West Yorkshire and Harrogate People Plan and also the NHS People Plan and People Promise. Next slide, please, Amber. Underpinning all of that, there will be sub-strategies. So there'll be things like our recruitment strategy, our development for all strategy, our talent management strategy, but they will all link back to one culture of care. And that's the key message for both the staff survey action plan, but also our workforce plans going forward. Next slide, please, Amber. To make sure that we are interrogating and progressing the actions that we've identified, Workforce Committee will be our key interrogator, our key critical friend, and we're going to try really hard to have a couple of agendas that we really focus on all the things that we need to improve. We'll also be looking at activities and progress against activities under People Agenda at PRMs. Next slide, please, Amber. We will also do a People Plus. The engagement team will be back out. So the return of the tea trolley. I know people are very excited about that, both the people receiving the tea from the tea trolley, but also the people doing that. And Lindsay Rogers very helpfully helped us with some IPC guidelines around that. We are taking part in an NHSEI pilot with a couple of trusts, about 7 trusts, I think, nationally, who are trying a TED engagement diagnostic tool and rolling that out. There's going to be an engagement board where we bring everything back, probably through Richard Hopkin, our wellbeing guardian sponsor for the board. And then, as I mentioned, the Team Values and Behaviour Charter, where we collect evidence from colleagues of positive practice, and each ward service department or team has on their walls what one culture of care and 4 pillars means to them. Next slide, please, Amber. So on there, we have quite a few actions that I've already referred to. I think the 2 things that I will pull out is one culture of care as our people strategy. We will not be diverting from that. We will promote a fresh start. The values and behaviours will be a key part of that relaunch. And the other thing I would absolutely implore on all of us is leadership visibility. So whether that be that you put on some scrubs and do some contact cleaning with our care club, or you volunteer to do some tea trolleys or collect evidence wherever you are, whatever you hear, so we can bring it back and really listen to what colleagues are telling us and do a you said we did approach. If colleagues who haven't been out for a while want to buddy up with people, then that's absolutely fine. I buddied up with a colleague last week or the week before to go out, just because it just does take a little bit of used to getting back to going on a ward and going to see colleagues, and we do have to abide by all the IPC guidelines in place. Next slide, Amber, please. So actions, there's a key day coming up, our appreciation or thank you day, which we've stolen from a trust down south east, which is a day dedicated to colleagues saying thank you to each other. There's going to be more management comms and engagement. The You Said We Did campaign, so pulling out the things that people have told us. Work Together, Get Results will be re-embellished and refreshed and relaunched. And there's some senior management and senior leadership development sessions going in for that. Next slide, please, Amber. And so in terms of our board response, what do we want from our board? So I really need your help, and I want you to hold me to account on making sure that One Culture of Care is our people strategy, and that we are having those difficult conversations for colleagues who don't abide by those behaviours or those values. We want One Culture of Care to be a meeting agenda, a standing agenda item on each board, and we need to hold each other to account. We need your help in making sure that the people agenda isn't just seen as solely owned by the workforce and organisational development team, and that it's as important as our money and as important as our recovery plans. In fact, this is the enabler to all of those things. We really need the board to get behind the values and behaviours, and then we're working up a leadership conference, and we're going to be a little bit more challenging with our message there. We have worked hard over the last 3 years to tell people and show people why One Culture of Care is the right way to build a good workforce, and a performing workforce and a happy workforce. At the leadership conference, we really want to test out people's commitment to that, and if they aren't committed to it, ask them to think about whether CHFT is a place for them. Next slide, please, Amber. So summary, national staff survey scores reflect our own decreases. Colleagues are burnt out. We can see that day to day. We need to reset, re-energise. As leaders, we all need to role model one culture of care and really stick with those values and behaviours. There's something to get the essence back of a team. And I think over the last sort of 6 to 8 months, we've kind of lost that approach as one team, CHFT as one team together, which is absolutely understandable given the pressure we've all been under. We do need to recharge. There needs to be quality conversations about appraisals, and then adding one culture of care to each meeting agenda so that we can make it real and share good examples of practice. Next slide, please, Amber. As I said, the Sheffield report from CQC did make a point of saying that the board didn't fully understand some of the detail of the staff survey. So we've put all the staff survey results there so you can go in, dip in, have a look. If you do spot any patterns that you think we have missed, then please let us know. And we are engaging the support of an external colleague who is very kindly offering her support for free to just come and give us a pair of fresh eyes in a very well-led way of saying, look, this is what we think, tell us if you think we're missing anything. So sorry, Philip, that was a bit longer than I would normally have wanted to take, but I think it was very important for the board to hear the key messages and also to hopefully come together at the end to commit ourselves to one culture of care.
The time is not a problem. I think the point is well made that the board needs to be fully informed. I'm just trying to check. I know Brendan was up there and I know Karen was up there. I've got Karen Heaton, Brendan, Andy, and then Alistair.
Okay, thanks. Thank you. I think the staff results are as we would have expected. I don't think there's any real surprises in there. I'm going to say what I always say. Annual staff surveys I find unhelpful, particularly when it's embargoed for a period of time. It really does make that you said we did bit really hard to get across for the next staff survey. So I say that every year, but I'll continue to say it until they change it. Maybe they never will. I think the board response is absolutely spot on. And I, for one, will be up for the tea trolley, and I'm happy to, for you to identify being a supporter, sponsor, mentor of a division. Happy for that to happen. I do think the emphasis, and I totally agree with you, has to be on leadership and managers here at every level. And I don't mean necessarily at the very top, but at every level, they have to be accountable for delivering this piece of change. It isn't just you, your team, and the senior management team. I think also about values and behaviours. We're really committed to these. We've always said we are, and we have to call out where we don't see it. And it doesn't matter who it is, absolutely irrelevant who it is, because for staff to believe that we believe these are important, they have to see that happening. And so we do have to take the bull by the horns, challenge. It's not the fluffy stuff. This is really challenging to take us into a different space. And I think that refresh of the people plan will give you the platform that you need to do that, and for the board. And I would emphasize including the board in that people plan as well. Thank you.
Thank you, Karen. Very helpful thoughts. Next, I've got Brendan.
Thanks, Chair. So look, this is all of our business, isn't it? Not just Suzanne and her teams. And I like the suggested way forward. And it's a but it might be an and. I think we need to be a bit more systematic about it, Suzanne. I think what we need to look at is a systematic approach to our leadership visibility. We can't be visible for the sakes of being visible. It has to be with impact and connectivity. And what we need to do, I think probably to your point and Karen's response, is work with our senior leadership team. So we don't end up in a situation where the board are highly visible, but actually that means our colleagues don't recognise our senior leadership team. I think we need to do this in partnership. It speaks to the whole succession plan piece then, I think, and our interaction with our colleagues. This isn't also just about the clinical areas. To your point, this is every aspect of our organisation, clinical and non-clinical, and more importantly, community versus acute. And then there's something about this isn't an inspection, is it? When we're out there, this isn't about inspecting. It's to the tea trolley analogy. This is about connecting with our people to understand what it feels like to work in our organisation. But I'm keen if we can just connect, and it might be something you want to pick up with Director of Corporate Affairs about that systematic approach to how we do this, and so that we work in partnership with our senior management teams. So again, it gives them exposure to us as a board, but it also means we're supporting them, because I know if I think to your highlight, I know medicine colleagues are working on this. Let's work with them on what they do rather than inspect them on what they are doing.
And then I'm just going to go and check who's next. I've got Andy Nelson followed by Alistair.
Yeah. So Suzanne, I share Karen's frustration about the timescales on this survey thing that takes forever, which I just want to come back to actually in a moment. So in terms of the themes that have come out, appraisal is an interesting one, isn't it, Suzanne? It keeps coming up. If we kind of compare to previous years, I don't expect a detailed answer to this. Are there other themes like that where we worked at it? So some things like health and well-being, fantastic. Well done to you and others about the improvement we've made. Is there something about some of these themes that we don't crack? Would we look at it a different way? And appraisals might be an example you talk about. And the Karen's point about us kind of leading and visibility, T-trolleys, sponsor, yeah, I'd be up for all of that too, absolutely. I think the sponsor thing, my question would be, what would you, if as NEDs, we'd play a role in that, what would you like us to do? Do we buddy, perhaps an executive plus a NED facing a division? Do we buddy up as a pair? What's a good way to do that? And what role would you like us to play? And then just back to this timescale thing, you talk about people pulse. Can you just remind me, what do we do? And I had a good discussion with Jim and the HIS about what's a mechanism we can use beyond the T-trolley thing that's a bit more quantitative, that is more of a continual survey, because the annual thing is just so frustrating. So sorry, a few things there, Suzanne.
That's okay. I'll take your last point first, if that's okay, Andy. So there's several bits of data entry points, really. Freedom to speak up is a big one, discipline and grievance. I reckon I get at least 10 presentations from colleagues a day. We all do. Brendan will get asked. Brendan, we've got that as well. The people pulse bit is now a quarterly bit that's done nationally, and that helps us with the quantitative bit. But in terms of our people strategy refresh that we're on with now, we're using all manner of things. So we're using Microsoft, the Microsoft Forms and stuff in a mini survey, and what we do is all of what we collect, so the things that you collected on your Easter tea trolley is brought back and is put into a database. So what we could probably do is something around the people survey, the people pulse survey, align it with that, and maybe do some local questions around some specific topics like appraisal. So appraisal, we know, is keeps coming up, and no matter how many times we change the form, it's the tone and the manner in which the appraisal is done that makes people value it or not. It's the conversation they have. And so what we are looking at more training, but we're also looking at changing the emphasis of ownership of the appraisal, so it becomes the ownership of the employee, not the employer, so the colleague versus the manager. And then also we're looking at ways that we can turn it into more of a conversation, so we would probably scrap the notion of appraisal. Lots of private sector organisations got rid of their appraisals years ago because of the very issue. Nobody will ever say that appraisals are good enough. A bit like communication. If anybody asks what's wrong in an organisation, you can guarantee no matter what they're doing on communication, the top one will be communication. In terms of the sponsor role, I think that is something that I would really like to work with the Director of Corporate Affairs on. It is that systematic thing, and I think it's the thing that you referenced on the back of the Easter tea trolleys, which is how do we do it in such a way that means that we're not doubling up, and so some places aren't getting anything and there's some people getting 3 or 4 people, and also how do we then check and go back with the things that we might have done so we don't have to memorise. It would still be a check-in, not a check-up approach to check, to check in with colleagues.
Agreed.
But we would be able to go back and show this is what you said to us and this is what we've done about it.
And just 2 quick follow-up comments. Yeah, I mean, on the pulse survey, getting specific questions around actions we're taking, I think would be a good thing to do. I'll be improving it. I agree. It's something that's worked well for me. And on appraisals, just a personal point, one of the biggest things from a manager perspective in my career is just the time you have to put into it to do it properly. So when it's not often done well, it was a brief peremptory tick box exercise. If I remember doing mine, it would take quite a bit of prep time, a conversation for an hour and a follow-up, and you have to put a lot of time in. And I think people just got to recognise that and give it its importance. And that's not the only answer, it's how you do the conversation. But often when it's failed in my career, people just haven't given it the time and importance. So no surprise, the appraisee feels not valued by the process at all.
Yeah,
thank you.
Thank you very much. Thanks, Suzanne. Alistair.
Yeah, I was just going to ask whether, Suzanne, you feel that a lot of this, the results that we're getting is due to the timing of when the survey took place. So, for example, the appraisals, my memory is that we suspended appraisals for a period, we then changed it, so it was much more light touch. And we kind of had to do that, and you know, we as a board took those decisions because of the, you know, the sheer pressures that we were under. And similarly, visibility, it was much more difficult, and still is, I think, but certainly in the past year or more, it's been very difficult for leaders, managers to be as visible as I'm sure we would have liked it to have been. So I think that you know, we shouldn't really be totally surprised by these results. It's a question of how we actually respond now, and to the appraisal point. In my views, it shouldn't be a once-a-year exercise. It should be an ongoing discussion that takes place. It might be formalised or crystallised once a year, but in order for it to be meaningful, I think we need to locate that in our expectations of leaders and employees in terms of their role and how they communicate and engage together. And just one final point in terms of the PMU, that this has come up, I'm sure, in previous staff surveys. I know Richard's comment in the chat, and it might be something specifically at some point that either Gary or Richard might want to report back to the board as to what's happening there, with obviously with the support of yourself, Suzanne, and the team.
Yeah, thanks, Alistair. And I think on that issue, that is one of the recurring themes, unfortunately. PMU, we haven't been able to offer this level of support, which makes the leadership team understand that it's their responsibility. I'll say that. I think that's the key point, and that's the key change that we will now adopt going forward, that this isn't something we're going to sweep up for people. As leaders and managers, that are accountable. It was horrendous at the time that the staff survey was carried out, but that's absolutely no excuse. And we can't, on one hand, be asking our colleagues to be really honest with us, but then not listening to them when they tell us what they think in the survey. So I think we should applaud the honesty that colleagues have given us. And I think if we look at this and our food and speak up concerns, and the notion of, you know, people aren't backwards at coming forwards at HFT, they will tell you what they think. And I think that is so important. And I would rather have lower than average engagement scores and the high performance, but know that colleagues are honest with us, than something that's not the reality.
Thanks, Suzanne. I'll now go to Tim.
Yeah, as well as all the really important stuff you've spoken about, Suzanne, if burnout was one of the themes, presumably people were feeding back a real concern about staffing levels as well. What are we doing about that, and how are we communicating that? You know, what the plans are?
So there's two ways of looking at this, and we look two ways sometimes on this. So actually, when you look at our turnover and our vacancy rates, they're better than they've ever been. So nursing has had an incredible improvement in terms of, I think we've got 60 vacancies now, and it's been 150 plus at times. So there's been so much work going on there. I think there is definitely a sense that the complexity that COVID inpatients have brought us, and the complexity of flow, has certainly made it feel like staffing availability is so far worse than in reality it is on paper, and it's really hard for colleagues. What I will say is our colleagues have pulled it out the bag every single time. They do raise with us when they feel it's unsafe, and we're able to do something about it. And I think that's the crucial point about CHFT, is that they will tell us, and they will bang on our door to tell us, and then we will go and sort it out, as opposed to not raising those concerns. But we have a really firm grip on our nursing staffing now. So our nursing staffing, daily staffing meetings are very forensic. We need to work harder on our medical staffing and adopt the same approach that nursing colleagues have. And then I guess Joe and I will work as well on the other stuff as well, so the support. And we found that what's had a big impact on clinical colleagues and the ability to deliver operationally and deliver our services is actually some of the support functions haven't been there in place as well. So there's the staff availability from a frontline point of view, but there's also the staff availability from the back support to them, and it all is in one. And where we're trying to get to is that we've got an overview of all our staffing so that we can look at it as a whole MDT, multidisciplinary team, all the time in each ward service department. So that's our aim.
Right, thanks.
That response, Suzanne. I've now got Denise. Denise wanted to ask a question, and there's a question for you in chat. I think that's just coming.
I'll be very quick. Just a couple of 2 or 3 comments from me, Suzanne. Yes, I'm very keen and willing to be involved in any of the initiatives, tea trolleys, etc. I missed out. I was disappointed I missed out at Easter, so I'm really keen to have another opportunity, if I may. One last comment about appraisals, and I think it's absolutely right to actually change, as you were saying, about the ownership of the appraisal, that it belongs to the employee. And I think one of the things that we may want to do is just to reiterate with all staff, so that they understand what they can get out of the appraisal process and how to make the appraisal work for them, so that they are in charge. And that, I think, would enhance and improve the quality of the conversations that are taking place at the moment. And the last thing I'd just like to comment on in terms of board response is about values and behaviours. I've had in the last few weeks, I've been able to speak to quite a lot of staff in different forums and at different levels within the organisation, and the recurring theme in many of those conversations have been about behaviour, poor behaviour, and whether or not, as an organisation, we really have the appetite to be calling out the poor behaviour. And this is, what's been shared with me is that there is evidence of poor behaviour at every level in the organisation. So actually, it's really important, and I'm really pleased to see that it's down as one of the board responses.
Definitely, Denise, and I think
Thanks.
that is the difference. Our colleagues are calling it out with us, which is quite right.
Okay, I'm going to go to Veronica. Well, she can still speak to us because she might disappear last time. You speak to us, and I'll make this the last one because I want to move on after this, please. Okay, Veronica, you'll have to contact me again. We'll be meeting up all next week. Anyway, I'll look forward to seeing you soon. We'll meet up to sort it out. We're asked to note this report. Are you happy that it's given a fair enough hearing at the board meeting today? Brendan, sorry.
Sorry, Philip, I know you want to move on. I think it's a really quick point, but we often look to our subject matter experts in these conversations, which is Suzanne and arguably Karen. But I think, as I said, this is our collective responsibility. I think there's a conversation going forward to ask Suzanne how she's going to hold us to account as a board. And I think, to Denise's point, this is something we get caught up in, all sorts of process, don't we, where actually behaviours may well have been tackled, but we're not feeding back to our colleagues on that. Or, to Denise's point, they haven't been tackled. And I think that's part of the cultural tide turn that we need to make about actually we are going to tackle some of this. And there are different levels of behaviour, but I think we need to just reinforce with colleagues to carry on speaking up, and that we will be taking action. But we need to task Suzanne, I think, to holding us to account as a collective board around what we're doing around this. Not to take the action, but to hold us to account.
Thank you for that, Brendan. I think that sums up where we've got to. We're asked to note this report. I assume silence is golden, so we'll now move on to the Medical Director of Infection Prevention and Control. Just to be clear, this is for something to approve. So I'll hand over to you, David, for you to bring this to our attention.
Yeah, thank you, Chair. So very briefly, colleagues will be aware of the format of this report. It's our quarterly DIPSI report, but also gives year-end data to the end of April, end of March, sorry. So I think a bit of a mixed picture through the year. I mean, clearly, as in the previous year, the infection control activity has been dominated by managing COVID, and we've seen a number of outbreaks on wards, as have all organisations. Those really probably reflect community transmission, and at times where you've got high rates of community transmission, you also see transmission within the hospital environment. But we've managed that well, I think, and numbers have been decreasing with COVID over the last month or so, so hopefully that will continue to show improvement. I think one of the challenges that we've had through this year has been clearly cross student individually, whereas you can see on the metrics we've exceeded our maximum objective of 22, and we've done that significantly. A mixture of hospital onset cases and community onset cases following hospital discharge. We're not unique in that. All organisations across the NHS have seen an increase in Clostridium difficile infections through the COVID period. Lots of theories as to why that might be the case. But probably importantly is the use of broad spectrum antibiotics in patients with respiratory infections and the age of the hospital population. But we're doing a lot of work around that. I think on a positive note, these were isolated cases. They were not parts of outbreaks in general, so control measures around spread of C. diff did remain effective through that period of time. Yeah, one piece of good news, I think, is that for the first time, I think I'm reporting an end of year position where we've had no MRSA bacteremias within the hospital. So I'm pleased to see that. And again, I think it reflects the efforts that all colleagues are making around IPC within CHFT. Generally, other metrics are good, or at least comparable to our peers. The MRSA screening for electives at 70% is partly a data quality issue, which we're trying to rectify, because there are patients in the baseline who should not be there and don't require a screen, but that is proving challenging. But I've left the metric there for comparison to previous quarters. I think with that, Philip, I'm happy to take questions. I mean, we've seen an occasional outbreak of norovirus as well. That's not uncommon. We usually see a limited number of those through the year. Last year has been no different. In fact, probably quite low norovirus activity within CHFT. And we've also seen low influenza activity through the year as well.
Okay, thank you very much, David. Are there any questions or comments to David? Given the report's quite comprehensive. Andy Nelson.
Just a quick one, David, on the C. difficile. How much of that is community, do we know, versus in hospital? And when it says unpreventable, what does that actually mean? Because you'd wish it not to be so high, clearly.
Yeah. So these are patients who've acquired a Clostridium difficile infection whilst they've been in our care, and I think it's up to 48 hours of admission. So it is likely that it's hospital onset. The community onset hospital acquired ones are those patients who've been in hospital and discharged within 28 days. So if they get a C. diff identified in the community within that time period, then they fall into that category. Each of the C. diff cases that we see has an RCA associated with it, and a decision is made around preventable versus unpreventable cases. And that's usually looking for a defect in IPC guidance or control or antimicrobial prescribing. So an assessment's made. It's not perfect, but it gives you an idea that I think for the majority of these, largely we were managing these patients in compliance with our antimicrobial policy and our IPC guidelines. We just want to remember, as you become older, then you're more likely to carry C. diff. Those carries rates increase significantly as you get older. So it's not something that you can eradicate from the population, but it's something that you can try and control.
So the unpreventable is almost that factor, is it? That you're almost carrying it to a level, yeah.
Yeah, 10, 20, 30% of people, depending on their age, will carry C. diff in their gut. It's normally controlled by the normal flora. When you get into a hospital environment and you're on broad spectrum antibiotics, it allows the overgrowth of C. diff, and that's what we try and prevent.
Okay, and that sort of drives the unpreventable in effect. of that actual situation. Okay, all right, thank you.
Thank you. No one else has indicated. Are you happy that we approve this report? Okay, that's fine. Can we then move on? Is Davina here? I can't. Yes, she is. Davina, good to see your picture anyway. Guardian of Safe Working Hours annual report, Q4. This is to note. Very comprehensive paper, Davina. Thank you very much.
Thanks, Philip. Can I just do a brief presentation, just highlighting the points? Is that okay?
Please do.
Thank you. Thank you so much. Okay, I hope you can see my screen there.
Yes.
Thank you. Okay, so I will be presenting the annual report for this financial year, and I have incorporated the Q4 data in this report too. So just summarizing the main points here. In this year, we've seen decrease in the exception reports compared to the previous years. Previous years, we've had more than around 110. This year, around 74. What we've seen is that there have been submission of these exception reports in all specialities. So, you know, the concept of exception reporting is embedded in our trust, which is good. Yeah. There was a slight increase in exception report from the medical division, which obviously reflected higher clinical workload, increased patient acuity and staffing issues during these recurring COVID peaks. The rota gaps were efficiently filled. Despite in between COVID peaks, we didn't introduce any escalated rotas for our junior doctors, and we were able to work on normal rotas since mid-March 2021, which is another positive. There were no exception report logged for immediate safety concern this year. And we have had improved engagement with the medical education team, myself and the junior doctors in the form of successful junior doctor forum meetings and trust induction. And good star point for us is that we have a new junior doctor lead for training recovery who will be focusing on improving training opportunities for our junior doctors. So if you look at the exception reports in the last year, majority of exception reports were in the Q2 and Q4, and there is a considerable dip in Q3. I can't understand the pattern to it, but overall a decrease in exception reports this year. If you look at the monthly exception report, again, it doesn't coincide with any COVID peaks. The two main months when we had more exception reportings were April and November 2021. Majority of them were related to hours of working and few to service report. There was no immediate safety concern issue raised at all, which is very good. And majority of the exception reports were closed on time with time off in lieu and payment. There were just a few which required work schedule review, but again, they were successfully closed after the work schedule review. The rota gaps, if we look at the monthly report there, overall around unfilled rotas would be around 5% in the trust, and the maximum unfilled rotas around was in the medicine division. Again, highlighting the positives for last year is appointing a junior doctor lead for training and active and engagement with the junior doctors through induction and junior doctor forums. And we advocated the importance to them that they need to participate as representatives, and we've got good volunteers as junior doctor representatives in our junior doctor forums now. We held 2 junior doctor forums in the last year, first in September and January. One was cancelled because of staff, sick leave and annual leave. And we are going to have the 4th one in May this year. The important outcome of the Junior Doctor Forum was updating a doctor toolbox in which we have put useful resources for the junior doctors so that they know what to do, how to book post-shift rest facilities, what are the important resources they need to know in the trust to carry out their routine clinical activities. Another thing we organized was Dr. Rob Mosey coming in and talking about reconfiguration plans in CHFT so that the junior doctors are up to, they know about what's happening with our medical education center, with the meeting rooms, and they can give their input into that. A star event last year was May 2021 when we had our fourth Junior Doctor Awards. Fantastic feedback, and the junior doctors' hard work was applauded in that. Looking forward to participate in the fifth Junior Doctor Awards, which is in a couple of weeks. The nominations have closed for that, and I have a meeting again in the afternoon today to discuss that more in length, but I'm sure it's going to be another success this year. Just highlighting another point, this year has been a training recovery year for the junior doctors. They have suffered because of lack of training opportunities in CHFT. And how, as a trust, have we helped them with that? We did a training needs analysis in summer 2021, and then we got some HEE training recovery money, around 60K, and that was used to fund a post of training recovery lead, Dr. Louise Finn, who's very actively engaging in the junior doctors and identify what they need, and that's what we are trying to supply. We have funded a post for a simulator lead and an ultrasound lead, and also encouraged more educational and clinical supervisor training courses for our consultant colleagues in CHFT. There have been some underspent monies from study leave. Again, that has been used to facilitate more online learning opportunities, like laptops for anesthetic trainees, laptops in the hub rooms, doing some simulation teaching for them, and doing some electronic journal resources and online exam preparation tools for them. So we have been actively trying to promote training recovery as much as we can, even though it might be virtual in most of the cases. So we hope to keep engaging, supporting the junior doctors and looking at other ways of providing training to them. And from the board, I would just want your support and your flexibility to carry on doing this in CHFT. Saying that, I just want to thank you because I have resigned from the post of Guardian of Safe Working Hours because I'm moving to Leeds Teaching Hospital Trust, which is close to home. I will miss CHFT. It is an amazing place, and I have learned a lot, and I loved my job engaging with the junior doctors, and thanks for the opportunity. But I might not be there for the next board meeting. So thank you so much.
Well, on behalf of
I'm happy
board,
to take any questions.
on behalf of the board, Davina, I just wanted to say thank you. You've always smiled across a crowded room, so thank you very much. It is appreciated, and your style and approach has certainly kept us informed. I don't know whether I want to wish you that well at Leeds Teaching Hospital. I know it's nearer home, but I wish to see it. I'm just joking. I sincerely wish you well because you deserve it, Davina. Thank you very much.
Thank you. Happy for any questions.
Any questions or comments to Davina, please? Karen Heaton would like to ask you a question, Davina.
Thank you, and thank you for everything you've done, Davina, and good luck with your new appointment. And thank you for the detailed report. It really was very thorough. And I just wanted to note the improved engagement with the junior doctors. That's, I think, really positive, and hopefully that will continue as time goes by. What I didn't know was whether the decrease in exception reports was a good thing or a bad thing. Is it a good thing?
I'm just hoping that the junior doctors are happy with whatever we are doing. I keep telling them that, you know, you need to tell me if you're not happy with something. So please try. So these junior doctor forums, we try to keep telling them, I would encourage you to put more exception reports. But what we are seeing is that majority of these reports are coming from the junior ones, the foundation trainees. As the trainees become much more senior, they know that if they have to stay an extra hour, it's for their good, and they get that time off. So we're not overworking. Majority of them seem to be happy. So from my point of view, I haven't, we've tried to resolve as much as we can if there is any unhappiness there, though I can't see much.
Thank you, Davina.
Thank you.
David, you wanted to ask a question or a comment, David?
It's a comment, not a question. I couldn't let Davina go without actually
Oh.
also expressing my thanks to her for taking on this role through the most difficult of times, actually, for medical staff. We all felt that Annie was going to be a hard act to follow, and I think Davina's really stepped into that role brilliantly and guided us through. It's so important that we give a good experience to our trainees, and she's no doubt contributed to that. Davina, you'd be a great loss to CHFT, both in the guardian role
I'm going to
and
miss it. I'm going to miss CHFT, but it's just 10 minutes down my house. So I had to.
All right.
CHFT
You're convincing
is 1
us,
hour.
Davina.
So.
Yeah, well, thank you.
Thank you very much, Davina. Much appreciated. I'll see you later. Bye-bye. Thank you very much. Bye-bye.
Thank you. Bye-bye.
Suzanne, I've got you down for the health and safety update. Yeah.
We're going to go straight to Richard, if that's okay, Philip. Richard Hill. And Richard, Amber's going to drive the slides for you.
Okay. Yeah, I just want to present what we've been doing over the last several months. This is an update really as to where we are since we started this process. I think around about 15 months ago when I first started with the trust. So just go on to the next slide, Amber, if we can, please. So this slide, I just want to introduce this slide. This is really the 5-year plan, the 5-year strategy. I thought it was important to introduce this at a glance. And what I would say is that we're making really good progress on each of these 9 subjects. So down the left, you can see all the priorities, and in yellow, you can see all the progress that's being made. I don't want to go into too much detail on this slide because of the rest of the slides, there's much more detail that reflects what you're seeing here. But along the top, you can see from 1 to 5, which is the years, and we're in year 2 now. And like I said, we're making really good progress on this. So what I'll do is I've gone to the next slides and I'll go into a lot more detail on this one. So in terms of the subjects I'm going to be looking at in the next couple of slides, then the first one is the NHS Workplace Safety Health and Safety Standards, which is our health and safety management system. The next one is a community division update. So we've been doing a lot of work over the last 6 months and more with the community in terms of compliance issues. The next one, number 3, is the accident reduction initiatives that we've been working towards. So we've got some subgroups set up on that subject. The 4th one is incident reporting improvements that we need in terms of the RIDORs. So these are the incidents that go straight through to the HSE. So the more the higher level subjects, incidents that happen, and legally we have to report these. So there's some discrepancies in terms of reporting on that subject. And then number 5 is a review of the ESR. So there were some gaps in there on a couple of the subjects. So I just want to outline where we are on that. So those are the 5 subjects. But if we go to the next slide, that'd be helpful. So this first one is the implementation progress that we're making on the NHS Workplace Safety Health and Safety Standards. Like I said, this is our version of the health and safety management system. And the standards themselves have been written by the HSE together with the NHS. So they work together on these standards, and basically it tells us what we need to have in place and what evidence we have to produce to meet compliance. So they are 1000% the best standards to use, and they are, like I said, designed by the HSE together with the NHS. So they're the best standards to use in order to demonstrate compliance. So if you look at the bar charts here, what you'll see along the bottom is the subjects that we have to show compliance against. The first one from left to right is occupational health, slips, trips, radiology, chemicals, sharps management, work equipment, Legionella, asbestos, and so on. So when I introduced these standards 15 months ago, a lot of these were either in red or in amber. And as you can see from that chart there, we are moving towards amber into green. And I reckon within 6 to 12 months, most of these standards will be in green, which demonstrates that we are meeting compliance. In terms of violence and aggression, I've excluded that from this bar chart because the results of that last review have only just come through in the last couple of weeks. So they will appear in future charts, and ultimately the aim for all these subjects is to get them into green. And once we have everything into green, we're at the stage where we can monitor and audit and produce dashboard results, so we get a good picture and we can maintain the momentum of where we need to be for the safety of staff and the well-being of staff. So we can just go on to the next slide, Amber, please. Yes, a lot of attention has been given to the community division, specifically around personal safety out there in the community, visiting patients' homes. So what I've done is I've helped the security and resilience team set up this subgroup, and it's been running now for the last couple of months. A third meeting is in the next couple of weeks, and I've managed to get representation from all these individual services that represent the divisional teams that go out there into the community, often by themselves in challenging situations where they might, for the first time, be going into patients' homes who have challenging behaviours, or in the community going from A to B late at night. So you can imagine some of the difficulties that they can come up against. So what we're trying to do here is get all the measures in place, whatever that looks like, from a personal safety point of view, to make sure that the well-being of these staff feel safe, and the board can be assured that we've got the right policies, the right procedures, the right risk assessments, the right devices in place, the personal safety devices for all these staff when they're out there by themselves. Just go on to the next slide, thank you. This next subject is ligature prevention. So I get the impression that CHFT are kind of like taking the lead on this compared to other trusts. And what we've done over the last 6 months is we've delivered online training to 440 colleagues within the acute hospitals, in both hospitals, around ligature prevention, because the risk is increasing, especially around ED, where patients are attempting to take their own well-being. So we've delivered this training, and we've also delivered the kits that nurses need in terms of releasing if they find themselves in these situations, patients taking their own life. So we're putting measures in place around that subject. And what we're planning to do, or what we are doing now, is doing exactly the same for a group of sites within the community. We've got patient interface, so Brighouse, Broad Street Plaza, etc. So there's about 3 or 4 different sites where we've got patients coming into the sites where there's perceived risk of certain patients potentially taking their own life. So again, this training will be rolled out, and the kits will be provided to a group of frontline nurses in these sites. Thirdly, in terms of community division, then I've been carrying out audits every 3 months, and as you can see there's a total of 9 months of audits done so far. And down the left, you can see the subjects that we've been looking at. It's been very much centred around COVID compliance in each of these community sites. So room occupancy levels, touch point cleaning, hand gel provisions, and seating arrangement for patients. So these are just some of the subjects that when I go around, I carry out these inspections. And you can see from the table there, every 3 months in total, we've done 9 months worth of audits, and the compliance levels are not bad, actually, I don't think. In terms of audit number 1, it was 100%, number 2 was 75%, and number 3 is 80%. So it's in a good place, to be honest with it. In terms of the gaps there, we know where the gaps are, and we are working with community and IPC to fill those gaps around some of the areas. Just moving away then from community, what I've also done is I've set up some subgroups around sharps management. So we have a subgroup now set up. It meets every 3 months, and we look at the DATEX results for sharps management in terms of the sharps injuries. So over the last 6 to 7 months, what we've developed is awareness posters just to reinforce some of the safe practices around sharps management. And in the last 3 months, what we've identified is we need to give extra training to junior doctors around sharps management, because what we've seen from the DATEX results is that there's been a peak in junior doctor injuries. So I'm working with colleagues to look at this and put some plans in place around extra training for junior doctors. Okay. In terms of this slide, what we'll also be looking at is floor conditions within both hospitals. So if there's going to be a potential injury or accident, it's predominantly going to be around slip, trips and falls, especially around the entrance areas. And that is both for patients and for visitors. So what I've done over the last 6 months is I've worked very closely with EQUANS and ISS and CHS together as a team, because we all have to play a part in terms of making sure we've got the right risk assessments in place, the right policies in place, and we have regular inspections of the floor conditions. So that is a piece of work that we've come together in the last 6 months, and we've produced new risk assessments and we've re-implemented the floor inspections. So I'd like to think that we've got a lot more confidence now to make sure that the floor conditions are in a good place. This next one is the reporting of accidents. Like I said earlier, at RIDOs, it's really important that we get accurate reporting for those types of accidents that go straight to the HSE. And it's not unusual for there to be incorrect reporting, but we need to do something about it, because what I don't want is the HSE to be receiving a mountain of RIDOs that should not have been reported, because they will come back to us and say, well, why are you reporting these accidents where they're not under the category of RIDOs? So it's going to create difficult conversations with the HSE if we don't do something about this. So as you can see from this bar chart here, you'll see that there's a reflection of those that are mistakenly reported, which are in blue, and those that are correctly reported, which are in amber. So you can see the patterns there. So what I need to do, and I'm hoping to plan it into mid this month, is to attend the Friday morning meeting, and do a bit of a mini presentation with band 7s and band 8s around this subject, just to reinforce the importance, but also the understanding of what types of accidents have to be reported through to the HSE. Yeah, I think this is the last slide, but this is about the training content. So I've done a gap analysis around the ESR training. What we do use is the National Framework ESR template, which all trusts use. And like I said, I've done a gap analysis, and usually there's very little content around those 3 subjects, very little content, maybe a sentence or 2, which it doesn't meet the requirements of providing suitable and sufficient training for staff. So I've done a gap analysis. I produced some more material, some new material, and we're looking at plans, next steps to really fill up those gaps, to make sure that existing staff and future staff get the best training that they can on these 3 subjects. And that's the presentation, Philip.
Thank you very much, Richard. Are there any questions or comments, Richard, following that comprehensive presentation? Karen, and then Andy.
Thank you, and thank you for that. And it's good to see that there's progress being made against the action plan, particularly a lot of, a significant process in completing those actions. One of the things that I felt was missing from the report was I didn't know the number of accidents and the type of accidents and where they were. And you've mentioned, in your presentation about, the peak in terms of junior doctor sharp injuries. So I have no way of knowing where that's all tracking. So I'd just like to see more data in the report so I can understand what the injuries are, but understand that, they're either coming down, they're going up, and I can then ask those questions. So that would be helpful for me. Thank you.
Good comment. And next I've got Andy Nelson, followed by Nicola.
Yeah, so Richard, lots of encouraging progress, as Karen has noted, so well done. Lots of good work there. And I would also echo, I was going to make Karen's comment as well, having some data in there would be really helpful to see the outcome piece, isn't it? We do a bunch of tasks, so we're changing the outcome. And then a question for you: if we benchmarked ourselves, I don't know if we do, against other trusts, similar trusts, how do we compare there? And then just a comment, I think, you know, we'd have picked up in the Security and Resilience Governance Group, wouldn't we, Richard? There's probably more to do on the violence and aggression piece. And as you say, we've not had the report yet, but there's going to be some stuff we need to do there. And I picked up a bit of a sense of T-trolley round that there's a bit more we need to do there in terms of, you know, helping staff.
Yeah, in terms of benchmarking, I think we're in a really good place. To be honest with you, I think we're actually leading the way in terms of the standards that we're implementing, and that we've got structure in place and plans in place and strategies in place. So compared to other trusts, I think we're in a really good place, to be honest with you, Andy, on this subject. In terms of security and resilience, yeah, helping as much as I possibly can to get where we need to be in the next 6 to 12 months around compliance. So for the safety of the personal safety of staff. So that's about policies, risk assessments, training, all that kind of good stuff. So I know Sarah Rother has set up a task and finish group, and I'm part of that, which I think is a great move. And I think that feeds into the ESR, into your group as well as a reporting structure. So I think at the next meeting, I think you'll get a good update as to where we are and where we need to be on that subject. But we've, like I said, I've done a gap analysis. We've got plans, or Sarah's got plans now in place for the next 12 months. And I think I'm pretty confident in the next 12 months that once these plans are implemented, from a compliance point of view and from a personal safety point of view on violence and aggression, I think we'll be in a much better place.
Yeah, there's work to do, isn't there, clearly? So, yeah, I agree. Okay,
Right.
thank you.
Thank you very much, Andy. Nicola.
Yeah, just great to see that staff safety's been taken with that proactive stance. And it's a key issue, and I think it feeds into some of the pieces we've been talking about already around staff feeling valued and nurtured and looked after. It's absolutely essential. I just wondered, around that piece of work, have we done any collaboration with our social care, social work colleagues that a lot of our trust colleagues work alongside, who also have those kind of personal safety requirements as well, to ensure that they're equitable, I guess?
Yeah, I mean, in terms of some of the community members of staff that work with social services, a lot of them do share some of the workplaces, especially the clinics out there. I think there's probably about 10 clinics out there. So it's interesting you make this point, because this is a piece of work that's underway now in terms of that collaboration approach with other services, social services, especially around lone working and personal safety out there in the community. So in the last couple of weeks, that's a piece of work that's just started. So yeah.
Oh, I'd be really keen to hear the outcomes of that moving forward. Yeah. Thanks, Richard.
Are there any other questions or comments to Richard? Can I just say thank you, Richard, and for also sending me a personal note. It was appreciated. So you look after yourself, and thank you. I'm going to move on if that's acceptable to everybody. Thank you once again, Richard. The next item I have down is the findings and conclusions and essential actions from Ockenden. So that's Shrewsbury and Telford overview reports. So I presume, Alan, you're going to ask someone want to introduce this?
Yes, thank you, Philip. So the paper in front is hopefully reasonably self-explanatory. The Ockenden review looked into the findings of a review into nearly 1,500 families' experiences at Shrewsbury and Telford, and the main findings from that were a failure to follow relevant guidance, that the governance systems and processes in place were ineffective. There wasn't good demonstration of multidisciplinary team working. There was a lack of board oversight into the issues and a general complacency towards quality, safety and incidents. And as Brendan referenced earlier, we are expecting other reports from Nottingham and East Kent as well. The first report came into the trust, and there was an expectation around addressing some immediate essential actions, and we did that and made our full return, and against those we were either partially compliant or fully compliant. The next stage of the Ockenden review then was the Ockenden 2, the final report, and the the expectation is that we'll undertake a self-assessment around the recommendations, and within the paper you can see the appendices which outlines where we are with those, and we need to make a formal response back by the middle of June. So on the appendix showing the compliance, that's been RAG rated, and you'll note that there are some red areas in there, and they've been marked as red, either that work is still ongoing, so reviews into various issues that we need to look into, or we are awaiting national or regional guidance around some of those. One of the biggest recommendations within, one of the more significant recommendations within Ockenden 2 is an urgent review of continuity of carer and the approach to that, and a decision will be made by the board in the follow-on meeting to this one around that. I think the important thing I'd like to get across to the board is that we have a number of opportunities internally where we look at a range of indicators. There is a national suite of indicators that we have to report into, and at local level across division, there are a number of management and incident panel meetings where there's an opportunity to discuss those, and we also have a perinatal quality surveillance meeting, which is attended by Karen Heaton as our NED champion for all things maternity. And when we look at our indicators, they are in line with expectations. However, we've taken the opportunity within the trust to go that step further. So within Ockenden, it wasn't just the hard indicators, it was some of the, in inverted commas, softer indicators about relationships and how people work together and feeling safe to raise concerns. So David and I have sent a letter to each and every staff member in maternity services, reminding them of the channels that they can use to speak out should they have any safety concerns. And we've invited somebody outside of the division in to undertake a review. The terms of reference are just being signed off as we speak, but that will be somebody who is experienced in maternity but sits outside of the division. And the reason that we want to do that is to try and get under the skin of any of those, and I do put them in inverted commas, softer indicators around how staff feel about working here, how staff feel about working together, and whether staff feel that we offer a good quality and safe service. So that will be a really important part of our ongoing response to Ockenden. And the main message here is that as an organisation and as a board, we absolutely need to make sure that we continuously challenge the data and that we have a regular review into some of those other softer indicators that we and that we could never allow a level of complacency to creep into anything that we do around maternity. It is a high risk part of our business, and we need to make sure that we respond fully as we can. So the reports in front of you, the current state of where we are in terms of the action plan is presented to board, and again we will continue with our, there'll be there's a section within the quality report as well around some of the data there. So I'm more than happy to take any questions or comments at that point, and we remain on track to submit our formal response by the middle of June. Thank you.
Okay, there are one or two people who want to ask you some questions. Just to remind people, there's a maternity services update internal review on our private board meeting this afternoon. I think according to my notes, it's Karen, Denise, and then Andy.
Thank you. I just want to echo everything that Ellen has said, and to say that, you know, there is a regular monthly actually surveillance meeting which involves external people, particularly the LMS. So we have got input. We can actually get a comparator of where we are, so we can get a good feel for where we are. Totally agree, it isn't just the data, it's what does the service experience actually feel like to you as a would-be mum and as a new mum. And I'd just really like to record our thanks to Karen Spencer. I know she's just retired, but she has really been, I think, a really good leader in all this for us. And while she's very, very modest about it, she has actually had a superb input. And I really just want that recorded. Thank you.
I'll just underline that, but then I'll move down to Denise.
Helen, thank you very much for the report. I just want to add two things. Firstly, just in case no one is aware on the board, that on a monthly basis we receive a maternity report at the Quality Committee. So we do have a lens every month on what's happening in maternity services. Can I say, Helen, that I'm really, really pleased to hear that letters have gone out to every staff member. That was going to be my question to you about how do we know that we've got the right culture in the maternity services, and you know, some of the issues that were identified about them and us attitude, etc., and poor working relationship and communication elsewhere, that we haven't got any of those issues. So I'm really pleased, and I look forward to getting the outcome of that. So thank you very much, and also ditto in terms of Karen Spencer.
Sorry, Andy, you wanted to ask a question?
Yeah, just one comment, one question. So the comment that I would echo the letter point. Great to hear we've done that and really try and get that very personal feedback from people. Hopefully that vehicle works. Won't always work for everybody, will it? But we've made the offer, which is great. And just an assurance question by May Ellen, that we've got the assessment there. Thank you for that. Very transparent and clear about kind of RAG rating against all this long list of things. Have we now shifted to kind of, if you like, a clear action plan? So if we kind of said that the obvious thing that would come from that would be there's actions and owners and dates, we've got that. And is that what Denise would see at the quality committee? Is that the vehicle we're using to look at the action plan?
Yeah, absolutely. And then that will just build and build as we get information through any freedom to speak up channels, or any update to the actions that we have in place. So yeah.
Okay, thank you very much for that. Are there any other questions or comments to Ellen? We're asked to note that. We're now going to move down to the quality report, which is Ellen again, and she's going to take us through the quality report, and we're asked to note the quality report.
Yeah, so and again, colleagues, please be aware that this has been through the quality committee and was subjected to some confirm and challenge within that particular forum as well. Again, I'll take it as read that everybody has been through the report, and I'll just go through some highlights for everybody. So in terms of the Care Quality Commission, Care Quality Commission have been on the patch across West Yorkshire currently, undertaking one of their system reviews around urgent and emergency care pathways across health, social care, primary care, etc. We have been on standby in case CQC were coming into our ED as part of that review. We know they've been into a number of EDs across West Yorkshire, and to date they have not visited us. However, they are on site on the 12th of May next week, when they will be doing a visit to the organisation. It isn't an inspection and it won't be rated, but nevertheless they are on site with us, undertaking a bit kind of deeper dive in terms of engagement with us. We have a process in place, the Journey to Outstanding, so our J2O reviews, and there is a full suite and a timetable for all areas to be looked at as part of that. And we've also introduced over the last 4 weeks what we're calling focused Journey to Outstanding reviews, so focused J2O reviews. And a number of my board colleagues have been involved in that, and we're going the process is that we have a look in those areas, and then we get some early learning out ahead of the full J2O reviews, and they've been really helpful. They're a very supportive process, and we've been able to make some rapid changes as a result. Next area then, dementia screening, which gets a focus at the quality committee. We're not where we need to be around dementia screening. The team are having a renewed focus in our assessment areas, which is where much of the dementia screening should take place, as well as our orthopaedic ward. So we're hoping that there should be some early learning from that, and again some rapid improvements around patient experience. Then some of the highlights: careers. A carers strategy has been agreed at the patient experience group. We've got some really good work going on with volunteers who, if you walk through our main entrances, or when you do, you will see them and hopefully be greeted by them. And we're using our volunteers now to increase our uptake of the friends and family test, as well as doing some at bedside discussions with patients where safe to do so from an infection prevention control, and just seeing how patients are feeling, etc. Around complaints, you'll see that we continue to have challenges around our performance data. Some of that relates to sickness and absence within the team. Much of the delays sit within the medical division, and we're doing some focus work within medicine. We've introduced a rapid some of the delays are around investigating officers as well. So these are people who are clinicians, generally speaking, working out in clinical areas, and it's no doubt that there's been they have competing priorities. So we need to focus on the systems and processes, but with a real focus and support into the medical division. And I've agreed some extra support into there this morning. There is a theme with communication with relatives, and that's something that we need to address as a matter of urgency. Around incidents, then you'll see details of incidents within the report and also details of learning from incidents. This is a really important part of closing the loop and getting that cycle of continuous learning embedded. You'll see some commentary around the quality priorities, and we had some discussion about this at the Quality Committee, and we've certainly seen some serious incidents resulting in harm as a result of falls. There is a link between staffing levels, and we look at all of those within the serious incident panel. And one of the factors contributing to that seems to be just how ill some of our patients are. Our patients are sicker, our patients are older, and our patients have probably are not accessing primary care in the same way, and preventative services in the same way that they would have done pre-COVID. So we know there is a link there. As a result of that, we've introduced a weekly review where we look at high impact interventions, and I've got a series of rapid learning and rapid interventions to try and address some of this. I've just talked about maternity services around the Ockenden review, and hopefully you'll agree as a board that our data shows a level of transparency that's coming into public board, which is a really important part of how we gain that oversight and how we gain the trust of our local communities and service users. You'll see in there that there are currently 4 cases with the Healthcare Services Investigation branch into maternity services. We've talked about the perinatal quality surveillance meetings. You'll see there data in relation to some of our outcome indicators, and 2 of the very important indicators which we're doing really well on is the one-to-one care in labour, again a key safety indicator, and also the level of supernumerary labour ward coordination. And I've talked about the maternity services review. So I'm more than happy to take any questions or comments at this point. Thank you very much.
Alistair wants to ask a question as well. I presume this has all been through the quality report, quality as well. Yeah, it was on the minutes I read. Alistair, and then Richard, and then Andy.
And thanks, Ellen, for running that through with us. You referred to incidents. A note in the report, it says there have been 755 incidents in March 22, which is a decrease from 718 reported in February. That should be, I think that should be increase rather than decrease. It's on page 3 of the report, page 173 of convene. And I think it's not just a semantic thing. I think we do need to understand that the incidents have increased, and indeed that I think it's 14 of them resulted in serious harm or death. That there is something around the lessons learned, but it's at quite high level. Just wondered if you could comment on, was this sort of gone through a quality committee or in other areas in a bit more detail as to the reasons for the increase in incidents, and particularly those that resulted in serious harm or death?
So all incidents go through a divisional panel, Alistair, and those that score, those that are rated as the most severe. So our red rated incidents come through a serious incident panel every week. Myself and David chair that panel where we go through the reports. The reports are then subject to investigation, and we expect the whoever's coming to present the data to have gone through to assure us of any rapid action that's been put in place to address any whether there's any instant learning, any changes that we need to make as a result of that before it goes through the full review. Some of those are reported externally, some of them meet the STICE reporting threshold, but all of them will then go through their divisional panel as well. Denise, into Quality Committee, we receive an overview of all serious incidents. So there's an incident, a specific report relating to incidents. So they go through divisional quality safety boards. They go through the corporate quality safety board, and they come into the Quality Committee. If there's anywhere there's a theme, Denise will often commission a piece of work around a deep dive into some of those. So one of those, an example of that would be falls, etc. So they go through a level of scrutiny. The reason that the some of the learning is quite high level in this report is because I need to maintain patient